I'm Dr. SreeniEdakhlon. I'm the chairman of the Scientific Committee of Kerala Society of Ophthalmic Surgeons. We have the Scientific Committee of KSOS has started this program basically to guide those doctors who are in the early stages of their career or the final year PGs, or even those who are established practitioners who want to, who have not been operating every day, day in and out, and they're not really confident with their surgeries. To give them an idea as to where all training facilities are available, long-term, short-term, so everything. What I've asked all these hospitals to do is to give an overall idea about what all training facilities, not just long-term, short-term opportunities, even the short paid fellowships of because those who are really into practice can't spare 1 year and go for training. So we this is the second day of the program. Yesterday we had Arvind Eye Hospital, Arasan Eye Hospital, RP Center, Vitala International Bangalore, Vivekananda Mission Midnapur, and Little Flower Hospital Angamali. Today we have another 8 hospitals: Sri Sankara Deva Nethralaya, HV Desai Eye Institute Pune, Shankar Eye Hospitals, Sadguru Nethralaya, Narayana Nethralaya, Sushrut, Megur Eye Hospital, and MN Eye Hospital. So these are the hospitals will be participating today. And first we will have Sri Shankara Deva Nethralaya. We have thank you, sir. Thank you, Dr. Harsha, for taking up, sparing the time to join us for this meeting. We really appreciate it. Dr. Nilutparna Devi, I've known her, very energetic young doctor, my LDP colleague. She's an associate consultant in pediatric ophthalmology and she's in charge of training residents in the hospital. And we have Swanubhuti Jain and Dr. Sanchari, who are it's a good idea to have some of the juniors who get trained there. Thank you, Dr. Nilutparna, for including them also in your program. And I request you to take over and start the talk from your side.
Yes, so we'll be sharing our screen now. Just let us know if this is visible.
Yeah.
Is it on screen mode?
No.
Okay, thank you so much. So hello and good evening to everyone. I am Dr. Nilutparna Deori, and sir has already given me I'm really humbled by his kind words. And actually, we are here to talk about the residency program, especially for the residents, DNP residents, and also for the fellows who have joined us. We'll be talking more in details about the DNP residency program and also give you an idea about the fellowship program. So we are thankful to you for giving us this wonderful opportunity. And at the very outset, I would request our President, sir, Dr. Harsha Bhattacharjee, sir, to give an outline of the institute, followed by which we will tell you about the training and the teaching module, the wet lab and the dry lab training, the preferred surgical techniques that we do here, the courses that we have offered, and also the future opportunities that you can get in this institute. So over to you, sir.
Thank you very much. Thank you for the kind words. Sri Sankara Deva Nethralaya is a Center of Excellence in Eye Care. Since its inception in 1994, SSDN is serving the people of Northeastern region with inclusive ideology in the field of eye care, ophthalmic education, research, and community services through 3 integrated institutions. SSDN main is offering secondary and tertiary eye care with cutting-edge technology, various support services like molecular biology, ocular pathology, etc. SSDN IO means Sri Shankar Deva Nethralaya Institute of Ophthalmology offer postgraduate ophthalmic education, residency training programs, fellowship programs, paramedical courses, etc. The third institution, SSN ICO, that means Sri Shankar Deva Nethralaya Institute of Community Ophthalmology, offers primary eye care in the rural community with the principle of integrated people-centered eye care, and by integrating primary eye care with primary health care and people empowerment. At present, Nethralaya has adopted 1,600 villages, and with an idea with a mission mode to make these 1,600 villages free from avoidable blindness, and 200 villages have already made free from avoidable blindness. So SSN main institution is offering the treatment of the patient who are brought from the hospital by transporting them. So with this, I request Nilutparna to conduct the course.
Thank you, sir, for outlining the mission and vision of the hospital. So as sir has mentioned, when we are looking at the residency program, we are actually looking towards an excellent training and teaching program along with a commitment. So along with a commitment to patient care. So we feel that all these qualities in the residents should be honed during the residency program. And in order to do so, we try to give them the maximum of the resources that we have and also try to improvise in those resources that we are lacking in. So the surgical residency program, especially for the SICS and the FACO training program for the DNBs and residents, and also the comprehensive fellows, the residency program is very thoughtfully curated from the first year to the third year. And we try to initiate the training program, that is the surgical steps, we try to give them early on, very early on, within the first 3 months, where they are inducted into the program and are given classroom teachings, followed by the OT ethics, etiquettes, the classroom theory classes for the block duties, sterilization, and thereby they try to assist the senior residents during their surgical procedures. And when we come halfway through the second year, they are also given subspecialty postings wherein they learn about different varieties of subspecialty surgical procedures. And also in the meantime, they get to know something more about the research, that is the molecular biology, the genetics, and all the research facilities are also provided to them. By the third year, they become independent in their individual cases, and they also start mentoring the junior students. And I would like to outline this, that in the first year, the module 1, I will discuss the module 1. Module 1 is completed by 6 months of their joining in this institute, and they start the SICS module 2, that is steps of the surgery, by the end of 6 months. But the surgical procedures or the steps are done in a supervised manner, not by the mentors, the senior mentors, but by the consultant themselves. We record all the videos and maintain a detailed logbook for every surgical procedure so that we can have a progress of their surgical training during their stay with us. In the second year, they are given peripheral center postings where they experience how to treat the patients in the OPD and also in the emergency room, where they get an exposure to various ocular pathologies and their treatment protocol, that is the management protocol in these emergency situations. Frequent cases and surgery audits are also done with video recordings and teachings. Specialty surgical rounds, as I have already highlighted, are also given to them in the departments of cornea, glaucoma, retina, and various other departments like microbiology, pathology. We do have the microbiology and the pathology department in our institute. The ICO Oscar grading system is finally given to them, apart from the self-assessment scoring, when they are doing their full cases, and we score them accordingly, which is a detailed scoring system. In the third year, they do independent OPD and OR postings. The comprehensive OPDs are usually curated for them so that they can get an extensive outline of all the ocular conditions and how to manage them. The complicated cases by this time are done by them, but it is done under the supervision. And whenever we feel that we need to take over, we take over the cases and teach them how to deal with these cases. They start mentoring the juniors. And in order to build up their leadership quality, we also choose a chief president who not only helps in bringing out what is the best in each of the student, and also makes a note that every student gets a turn when they are supposed to do their surgical steps. They also learn how to mentor them, and they assist the senior most residents in doing so. So in module 1, there is the orientation in the first month, especially in the classroom orientation and also the hospital orientation. As sir has mentioned, we have 3 buildings where we make them go by rounds, and also the subspecialty units where they need to see how the patients are being dealt with. They are also given shadow postings in the 2nd month of their joining with their senior residents. And the wet lab is included in the 2nd module, where they complete the wet lab by their first year of their training, and they start their surgical steps. But before they complete the first year, in the 6 months of their training, they can start with module 2, which I have mentioned, with the side port and the conjunctival peritomy. Finally, we go into the module 3, where there is the sclerocorneal tunnel and continuous curvilinear capsular access is being taught to them in different scenarios, in different types of cases. And in module 4, there is a nucleus prolapse, irrigation, aspiration, where mostly the students have more difficulty, and finally the IOL dialing. So over to Dr. Swanubhuti Jain, who will tell us more about the dry lab orientation.
Thank you, ma'am. We have a structured training program here to learn, practice, and improve our surgical skills. Before starting the dry lab, there is an induction into the teaching program, where we first spend time in the classrooms, where our mentors teach us in depth about from the anatomy to blocks to the surgical procedures. This also includes inculcating ourselves with all the right OT ethics and etiquettes. There are also practical demonstrations on proper hand washing techniques. Also, sterilization is a central core of any OT. There we are made to be well versed with all the sterilization techniques and their importance. I would like to state that to achieve any skill, one must be familiarized with the machines and the instruments, the microscopes and their handling, the instruments in the dry lab as well as in the wet labs. To acquire, one must study, but to acquire wisdom, one must observe. Therefore, students are made to assist and observe before they start their surgical journey. They set their own OT trays, clean and drape the patients, and learning the importance of each and every small step. The dry labs are extremely important training tool, which gained much importance during the global pandemic COVID-19. They help the trainee surgeon to get exposure regarding the ophthalmic instruments, practice steps of surgery in a risk and stress-free environment, and allowing them the chance to execute the steps of surgery repeatedly without the risk that comes with the real eye. Various steps of cataract surgery, such as capsular access, can be practiced over a tomato or a boiled potato, aluminum foils, and also on the Cataract. The art of learning to make a sclerocorneal tunnel forms the basis of any SICS surgery. So this step can be well practiced over a lemon or a boiled egg. For improving the stability in the fine motor skills, we also practice with fine paint brushes. Also, besides surgical training, our program encompasses a holistic approach to wellness. This includes refreshing weekly book clubs and yoga sessions to enhance our surgical flexibility and mindfulness. Handing over to Dr. Katharina.
So over to Dr. Sansari, who will be talking about the wet lab training program. She is a final year resident.
Thank you, ma'am. So moving forward, after the completion of the dry lab training, we are made to practice in the wet lab, especially on the goat's eye. We procure that from our local butchers. And the wet labs are an extremely important training tool, especially in the times of global pandemic, where we don't get much exposure in the surgical field. And the first thing we have to learn in this wet lab is the fixation of the eyeball in a wooden head. We stabilize the animal eye in the empty eye sockets. Thereby, where we have 3 stations with a recording system and with phaco machine. Mainly, After fixating the eyeball properly, we start practicing, and that's how it helps us in a more time, spending the time in the wet lab, enhancing our psychomotor skills, hand-eye coordination, ambidextrosity, which are all very important in our branch. Now, we also have 3 stations with recording system, which also have the SICS and the FECO system. Now, mainly in the goat's eye, that capsular access is very difficult at the beginning, but with practice, we can perform peritomy, sclerocorneal tunnel, all these steps quite enhancingly. And then we move forward with our video analysis. Each and every surgical cases are recorded, and it helps us in our self-analysis. We also go through our thorough pre and post follow-up for each and every patient we see in our daily basis in our hospital. And after this, there is one example of this performance graph, which is made on basis of our self-analysis, which we identify our weakness and the shortcomings, and we discuss those with our mentors for our further improvement. Now, according to our highly detailed ICO scoring system, it gives us a definite scoring of our cataract surgery and help us to track our progress over a period of time, like in the 3 years of our residency. We also, this is one of our example of our learning curve, as we can see as far as the Oscar grading system over the 3 months of 3 times. Although the observation remains the most important aspect of the training program, it also enhances that the teaching and practical training also help us in the improvement of our skills. We also get our peripheral center posting, like in Tejpur, where we are mentored under our senior fellow, and we learn to analyze and assess the patient of cataract surgery needed for cataract surgery, and we also learn to run a center independently. So that's all. We'll hand over to Dr. Randy now.
Yeah, thank you so much. Dr. Swanupati is our first year primary DNB student, and Dr. Sanchari is our final year resident. This is secondary DNB. So where does the future lies with all this training program? We feel that each and every student teaches us something new during their stay here. And in order to do that, we try to improvise. We are actually looking at the simulator system right now. And we hope that it will be at our institute in a very short period of time, and that will actually reduce the amount of the training that they achieve in the wet lab, and that will and by this we can actually enhance their surgical skills more. So along with that, we also have our online training program across the state, and what we feel that by teaching and training them, we are creating more mentors and more trainees in the form of increasing the number of surgeons across the state and also across the nation, because we have students, that is fellows, coming up from different states and also from across the globe. We have foreign fellows also who comes for our training program. So our preferred method of surgical technique, as I have already told you, we usually go ahead either with a straight incision or a frown incision. And however, the basic SICS training is not the only one that we prefer. We also train the students in the advanced SICS techniques like the chevron technique, the temporal incision, the topical SICS, as well as also the 2 millimeter incision, which we are doing at our institute right now. And that is open for all the other students who can come and learn our advanced SICS training program. Once they have completed their SICS training program, by the beginning of the 3rd year, they are given exposure to the FECO training program, wherein the steps, the modules are again the same. They follow the same classroom teaching, and then they go ahead with the wet lab and then the individual cases by 3rd year. So this is one of the surgical steps. I think I can skip this video. So, okay. So the programs that SSDN is offering is people are actually looking at more at short-term fellowships, and also after the completion of their masters and the DNBs, most of the students are also looking at long-term fellowship programs. For short-term fellowship programs, surgical training programs for SICS and FECO is available in the form of 15 to 20 cases in SICS. And according to the surgical equipment, sometimes we tend to give them more cases, and it costs around 25,000. And for PECO, it is 20 to 25,000. And as we have mentioned, as per the surgical equipment, we can increase the number of cases, and the payment goes up to 50,000 in this situation. Long-term comprehensive fellowship gives you a general view of all the other subspecialties, but also gives you an enhanced and more skills in SICS PECO as well, because in the first 18 months they are trained as a fellow, and in the last 6 months of their training program they are inducted as an adjunct faculty, where they get the stipend in the salary in the form of junior consultant, and in the first 18 months they get the stipend of rupees 40,000. The subspecialty training programs are also similar. We have subspecialty training programs in oculoplasty and orbit. We have in pediatric ophthalmology and strabismus. We have in vitreoretina. We have in medical retina and uvea. We have also short-term fellowships in medical retina and uvea. And in pediatric also, we have short-term 3 months of training program. And along with that, we have glaucoma long-term fellowships. We have short-term fellowships also for glaucoma. And these fellowships are, short-term fellowships are for 3 months, and the long-term fellowships are again 18 months of as a fellow and 6 months as an adjunct faculty. So the future opportunities at this institute, I would like to mention here that as Srini sir has already mentioned in his introduction slide, that myself and my colleague Dr. Shamsundar Das Mahapatra, who could not be here because of his viral infection today, we both were trained at this institute, and we have joined as a consultant at this institute, and we were trainees at one point of time, and now we have become trainers, and we are mentoring a lot of students here. So I feel that the future opportunities at this institute is very, very bright. And if you are not joining as a consultant at this institute, you are trained in such a way, in a very holistic way, that you can be confident even in your private practice when you go out of here. So we feel that we need to pay it forward while giving our teaching and training program. And thank you so much for giving us this opportunity.
Thank you. It was a comprehensive presentation on whatever your institute is offering. See, you just said these are the number of surgeries that you get for short-term training. What is the duration? 4 weeks, 8 weeks for your short-term training for
2 months.
2 months for FICO, and so is there an how do you screen those who are coming in? Because do you take a greenhorn just for FICO training, short-term training, FICO training?
No, we assist them when they come to us.
No, that's fine. No. What is the criteria for selection? Like anybody who applies would get selected, or
no? No, if like they give the CV, they tell us how much they have done, what is their area of difficulty, and where they need to train up more. So all those things are taken into account, and then only we select them accordingly. But for the paid trainees, definitely, even if you pay, and if you have not done a single case, then it becomes difficult for us to train you within 2 months with just 20 cases. So that is those criteria are definitely there.
So do you make them initially work in your wet lab and then go for
yes, so they also have to follow the same module 1, 2, 3, 4 up to the end, and once they have finished the module 4 and they are doing their independent cases in the OT, then we decide that if they are doing good, then we can give them further more cases. So sometimes we do have the liberty of giving them a little extra 1, 2 cases more.
And see, what are the duties for a fellow? I mean, paid is different. So what are the duties? Do they have to join for fellowship? Do they have to go for camps? And if they have to go for camps, how many camps? And what are the leave rules that are there?
The leave rules are equal for all the fellows, 30 days in a year. And they do get leaves. This leaves includes your academic leaves, your CLs, your MLs, everything. And not only the leaves, we feel that they should be very punctual and disciplined during their stay here. So we tell them that they have to come on time and leave on time. Along with that, the question that you have asked regarding the camps, we have our referral centers where they need to go once in a month or according to the rotation that they get there, because we have a lot of fellows and students here. So my student has already mentioned that a fellow and a DNB resident usually they go together for this camp. So once in a month it usually comes. So.
And see, another major reason why I've taken up this program is see what I've seen in Kerala at least is that 95% of the postgraduates, ophthalmology postgraduates are girls, and so obviously they have a disadvantage when compared to the boys. So many of them get married at the end of the post graduation, then the family and everything. So do you give any relaxation to girls, like when they are doing their fellowship? See some pregnancy or marriage or whatever. I mean, it's a sensitive question to ask, but please, because I've been seeing girls and everyone struggle in their career, and they end up being optical because I just want to guide them as to see this is how you can go about it. So anything on that?
When we conduct the fellowship interview, at that point of time, we tell them very frankly about the program that we have. Especially, we ask them the question if it is women ophthalmology, that our duty hours are this much and this long, and will you be able to do the duty hours without any difficulty of performing your duties in daily basis. Especially, this is a family, this hospital is like a family to everyone. So each of the students tries to help each other. But we make sure that they can actually come into this fellowship program. Because if you have a child and you also want to pursue your fellowship, then you are not doing justice to both of them. You are actually not giving your full priority to your child and not full priority to your fellowship as well. So in that way, your fellowship is also a little bit less than what the other fellow, your co-fellow might be having. So that option is usually given. But apart from that, there are some institutes, very famous institutes like Dr. Shroff's Institute, which provides sandwich fellowships. And we are trying, if we can, to give the sandwich type of fellowships to women ophthalmologists who are facing this problem. However, the 2 months short-term fellowship that I have already told you, or the 3 months fellowship that we have told you, 2 months of surgical fellowship and 3 months of this fellowship in pediatric glaucoma or any other subspecialty. This also would act as a sandwich fellowship for them, because they have already learned what they need to learn during their residency program. The only thing is that during their pregnancy or during their maternity leave, they had a break. And in order to overcome that break, they can join us as a short-term fellow. And we feel that this will definitely help them out. So you want to add something?
Thank you, Nilutparna. I know that it was not fair to ask about it, but you answered it well. Thank you, Harsha sir, for letting her answer it. And thanks a lot, both of you, and Sankara Deva, Nethralaya, and because down south, I want all these kids to know about what our training facilities available in other parts of India, and you've clearly really well explained everything, and thanks a lot for being part of our program. I know that it was a short notice invitation. And,
yeah, actually, we have our pediatric ophthalmology conference here at Shankar Deva Nethralaya on the 20th Saturday. So we are a little tight on schedule. I'm really sorry for the trouble that we have caused. But thank you so much for adjusting.
Thanks a lot. Thanks a lot. Thanks a lot, sir. So thank you. Thank you. Yeah, you did well.
Yeah.
Okay. Okay. Thank you. Thank you. Bye. 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 Yeah. Now we'll move on to the next hospital and see. Ankit.
Yes, sir.
I have an issue with my laptop. I'm joining from my phone.
Okay.
So I'm able to upload. So I'm not able to see the other participants. Dr. Ashwini is.
I'm there, sir.
Okay. So I have an issue with my phone. I can't see who all are there. So and I'm not able to share the introductory slide also. But I'll just read that out. So why I have heard a lot about HV Desai Eye Hospital Pune from many of these kids who come for the conferences. I mean, even those. Who have been trained in Shankara, because I'm a Shankara man, though from RPC, but I learn my surgeries from Shankara because I meet them and we have Dr. Rohan here, who was a student of Dr. Colonel Madan Deshpande, and every time he starts talking about Colonel Madan Deshpande is in another level. Such a great man who. At this senior level, going around, and so that is why we actually called Sir for an oration, Dr. Shihota oration, in one of our KSOS Scientific Committee CME series, and the energy that Sir has is unimaginable, and we were all really inspired by him, and I'm sure. Everyone in HV Desai Hospital are also really inspired by Sir, and so those who don't really know about HV Desai Hospital, it's a huge hospital, and it's a leading tertiary eye hospital in Pune, and it was established in year 2000, and it's got all the it's really equipped with state-of-the-art technology, and it's got NAB accreditation. It's got a reach out program to 350 kilometers from the hospital premises. There is a provision for free treatment. That's more than 60% of the cases are treated free. The institute has a postgraduate and paramedical training. There are research projects going on there. All the possible ophthalmic subspecialties are there, and thank you, Dr. Ashwini Gaikwad, for sparing your time to join our program. And Madam is a cataract and glaucoma consultant, and Madam is also in charge of the cataract wet lab of HV Desai Hospital, Pune. Ma'am, please start your presentation.
Yes, sir. At the offset, I would like to thank you, sir, for inviting us. And yes, am I audible?
Yeah. You are.
Yes, sir. Dr. Madan Deshpande is he's like guru, and he's like legend to us. So we have, even I am the past student of HV Desai Hospital. Now I have continued as a consultant here. So he's like a god to us. So, and definitely no words to explain him. And actually, it was a little last moment thing, so he could not join. So he has extended his gratitude towards you. And he has asked me to continue with the presentation.
Okay, please, fine.
Share.
So is my screen? Yes, I will do.
It is coming. Yeah, it's come, and you can go for the full screen view.
So is it even now?
Yeah.
Okay. Okay, good evening, everyone. I'm Dr. Ashwini Gaikwad, and I will be talking on the cataract surgery training process in our hospital. That is actually Desai Hospital. It's an project of Pune Blind Men's Association, and it is a comprehensive institute with facility of quality eye care services and skill transfer. And as exactly told by sir, we extend our services to around 350 kilometers around Pune, and the community eye care service is our main facility. So apart from that, we do have a private wing as well. So apart from this, we are a training institute for the CPS DOMS students, the primary and secondary DNB students, and we also have cataract and all subspecialty fellowships, both short-term and long-term fellowships. So apart from that, we are involved in research activities also. So I mainly today will talk on the fellowship and mainly the cataract fellowship, the structure, how we do a cataract fellowship training, and what all are the opportunities we can offer to the various students. So we have a long-term fellowship. So we have a cataract fellowship, that is general ophthalmology fellowships. So apart from that, we have all other specialties fellowship as well. So in our fellowship, specialty fellowship, we do teach SICS and FECO to all the students. And short-term fellowship, so these are all 1 month or 2 months fellowships. These are mainly for the fresh postgraduate students who probably didn't have an exposure to those various subspecialties during their tenure, or the practicing ophthalmologists who would like to brush up their knowledge in particular specialty. So these fellowships are aimed for those people. So we have short-term fellowships for SICS FECO emulsification. Apart from that, all other specialties in addition to the low vision and retinopathy of prematurity. So these are the short-term fellowships offered in our hospital, and these are all paid fellowship. And the long-term fellowship are the stipend fellowships. So the aim of the fellowship is to train the budding surgeon in the well-equipped operation theatre in SICS and FECO surgery in highly sophisticated wet lab, to enhance the candidate's cognitive abilities, fine motor skill, the surgical judgment and overall surgical technique in SICS and FECO emulsification surgery in wet lab, to understand the steps and common techniques utilized for SICS and FECO, and then independently perform SICS and FECO surgery step by step, followed by oil implantation in operation theatre under the guidance of the senior ophthalmologist, and able to manage the intra-op and post-operative complication under the guidance. So these are the main objective of the cataract surgical training. So in our long-term cataract fellowship, we have 2 fellowship, a general opthal fellowship, it is around 18 months, and a comprehensive opthal fellowship, it is of 24 months. So in comprehensive opthal fellowships, in addition, we have in their last 6 months, they undergo monthly rotation in all specialties, and they get an exposure to the basic, the instruments, the various diagnostic tools, and the identification of the common entities, and the diagnosis and the management. So this part, if in last 6 months they do, so that is why the duration is more, and it is comprehensive opthal fellowship. So basically, the fellowship tenure in the first month, they generally observe in the OPD, and they take part in the eye care camps, then they visit vision centers and secondary centers throughout their tenure. So at the end of the first month is observation. At the end of first month, we start their wet lab. So they undergo wet lab training, and after that, from second month onward, the SICS surgery start. So SICS surgery, the stepwise, they do the surgery. So following the wet lab, only we start the SICS training. So in addition to the wet lab learning, simultaneously they undergo lectures, then seminars, then case discussion and grand rounds in academic section as well. So it is covered simultaneously. Then they have to do a online FECO module, the cyber site module for the FECO, the SICS and FECO emulsification. So this happens simultaneously at the end of first month, followed by observation and step-by-step learning of surgery in the OT. It starts from the second month onward. So, and that the assessment is done by the ICO Oscar scoring for wet lab and the surgery. In that, in detail evaluation of the steps, stepwise, the scoring is given, and it includes the scoring from the novice, advanced beginner, and the competent. So gradually they are assessed how they are progressing, and we give training for fecal emulsification in last 6 to 8 months. So when they reach the at the end, last 6 to 8 months, there again we start their FECO wet lab. So we have very sophisticated wet lab. I'll be talking on the wet lab in later my presentation. So they undergo wet lab training there, followed by a stepwise fecal emulsification learning under the guidance of consultant in hospital. So this is the structure of the long-term cataract fellowship as in concern to the cataract learning. So we provide both SICS and fecal emulsification short-term courses. They are paid courses, so duration is of 1 month. So all eligible candidates are all postgraduate students. They can apply for this course. So first week they undergo wet lab training, around 5 cases in wet lab, and simultaneously first day is observation, and then second day onwards in OT they do a stepwise surgery. Simultaneously they observe the cases done by seniors in the OT as well. And this is how the 1 month paid fellowship is there for SICs, and they get around 20 to 23 cases in this 1 month period. As they have to definitely they are involved in the pre-op evaluation of the patient and the post-op management as well, and the lectures are taken for them. So coming to the short-term fecal emulsification course, again it's a 1 month duration. So this course is specially designed for the eligible candidates are the all postgraduate students who want to learn fecal emulsification, and the senior surgeons or practicing ophthalmologists who have been doing SICS and then now want to convert to the fecal emulsification. So we have, we predominantly have these 2 categories of crowd which are coming to us: the freshers who want to learn the fecal emulsification, and also the seniors who would like to learn the fecal emulsification. So here I would like to, tell that last before 3 months, so we had similarly 2, gentlemen with international trainees who were there, who were in their 40s to 50, Dr. Theodore and Dr. Kintoki. They came from the Mozambique, South Africa, to us. So they underwent first a SICS training, then followed by a fecal emulsification learning, a 1 month SICS followed by 1 month fecal emulsification. So the paid fellowship they took with us, and they underwent training with us for the fecal emulsification. So they were doing SICS surgery in their hospital there, and for fecal learning they came to us. So this 1 month FECO course, it starts with the wet lab training. The highlight of this course is there is a very much one-to-one interaction, the trainee and trainer interaction. So they start with the wet lab. So they undergo 5 wet lab training. Simultaneously, they have to complete the 4 modules on the modules of cyber-site fecal emulsification modules on online platform. So and then they observe the cases in the OT, and they perform stepwise cases in the OT under the guidance of consultant. So we have very well-equipped operation theater with the side microscopes and TV displays, where the trainees can go and observe how the senior consultants are doing FECO. Okay, for these trainees also we do assessment by ICO Oscar scoring for both wet lab and surgery, and throughout the month they are assessed. They have to go and meet their trainer, get the scoring and get the signature. And in addition to that, this training, they also undergo training in A-scan biometry and IOL Master 700. So they also learn how to do IOL path calculation. So that is also an additional part of this. So this was about the long-term fellowship and the short-term SICS and fecal emulsification course. So now I would like to talk about the wet lab facility. So in our hospital, so it has been a crucial component of training module in our hospital. So we have been training our fellows and resident doctors for last 3 years with fully equipped state-of-art wet lab. And we have a fully dedicated clinical and programmatic staff which manages the wet lab. So we have a wet lab available for SICS and PECO. We do it on Kitaro eyes. And we do also have a wet lab for trabeculectomy that we do on Phillips eyes. So I will be mainly talking of the cataract wet lab. So these are the few photographs of our wet lab. So we use a separate Zeiss Lumira microscope and Zeiss Visualis PECO machine with side view attachments and display screen for the trainee observation and teaching purpose. There is also internal recording system. So this trainee do the SICS wet lab and a PECO wet lab under the guidance of consultant on the microscope, and on the TV screen, the consultant observes and guides them. And also there is a system for the recording. So they can just go back and have a look at the recorded videos as well. So parallel to this, we arrange the lectures on various aspects of the SICS and the fecal emulsifications by the consultants. And as I told, we generally take 5 wet lab sessions for both SICS and PECO. And then after finishing the wet lab session, simultaneously they do a stepwise cases in the OT, and they observe cases in OT as well. So these are a few more photographs of the wet lab where you can see the machines and the trainee performing the wet lab session, and the surgeon is observing. So all the basically they have to attend the CyberSat modules. It itself has a pre and post assessment test. So they have to complete that test, and then only they can go to the next module. So that itself becomes a good theoretical learning apart from the lectures taken by the consultants. So again, as I told, the ICO rubrics are used for both wet lab and surgery assessment. So the aim of the program is by the end of the program, the trainee will have a thorough knowledge about the safe OT practices, the SICS surgery, the PECO emulsification surgery, the PECO machine, post-op evaluation and management, and also the oil power calculation. So apart from the Kitaro and the Philips wet lab, so we have another feather added in our wet lab, that is a virtual reality-based training for the budding surgeon, the freshers in SICS. So that recently got added to our wet lab facility. So that from this, the fresh batch of the residents, we have started that. So now it is basically a course for the novice residents. So in which they do a animated SICS surgery. The idea is that they can do a repeated practice for the each and every steps. And there is a dashboard and which guides you that where did you went wrong, and you can repeat the step. So that I think that is very good thing. So they understand the exactness of the exact step they have to perform, and they are graded and they get exact where they went wrong. Okay, so these are the photographs of how the virtual based reality setup is. So it has a VR headset from the left. It has a joystick, a stylus, and a laptop with the course. So these are the images how after putting on the headset, how the OR looks, and these are the instruments in OR. So apart from this, I would like to add, as I said priorly, so we are the other hospital from the Shroff Charity Eye Hospital, which provides the sandwich fellowships. So in India. So HV Desai Eye Hospital and Shrub Eye Hospital, we are working on a project for the Sandwich Fellowship for the in glaucoma subspecialty. So where the, as sir, you said that we encourage the women ophthalmologists, where the half part of the fellowship is with us and the half part is at the secondary center, where I mean they come to us, and from digitally and virtually we monitor them in half of their fellowship. So that I would like to tell here. So this is the video of phacoemulsification on the Kitaro eye. So I would like to play it now. So how for the phacoemulsification from stepwise we can perform in the wet lab. So this is very, I mean, good guide. So here, starting from the incision making.
Ma'am, the video is not playing.
Yes, I will show you. So this is a Kitaro eye. So here, from starting from the incision making till the phaco 3, we can do all step phacoemulsification. So here you can do the trainee is doing the CCC. And basically, it is a very good, guide for the people who are very novice or who have never done the phaco prior. So this gives very good guide towards the orientation in anterior chamber, and also it gives very good orientation with the machine, the machine programs and the sounds. So with this, the initial that hesitancy with the hand, eye, and the fit coordination which occurs in all learning, the initial novice residents. So that can be, tackled in the wet lab only, so that they can pick up fast in the patient and with less complications. So here the trainee is doing the phaco, the trenching. So now the trenching is complete, and now the training is doing phaco 2. So now we are shifted to the phaco 3, that is the aspiration of the epinucleus sheet, and the surgery it is complete. So this is another video of doing a small incision cataract surgery on the Kitaro eyes. So here for small incision, we can do the incisions, the tunnel and the CCC and the entry. So now the trainee is doing the CCC. Now the trainee is doing the, now he is making the tunnel. And this it really helps. So it gives a good judgment, and it is quite similar. And now the trainee can practice the suturing. That's it, sir.
Thank you, ma'am. Can you unshare? Yeah. Thank you, ma'am. See, I would be interested in knowing more about the Sandwich Fellowship, because as I said in the beginning, my main concentration are all those girl PGs and young women ophthalmologists who find it difficult. Obviously, it's not as easy as boys. So you said the sandwich fellowship is going to help. Could you please explain more regarding that?
So actually, the sandwich fellowship is introduced to us and in Shroff Charity Hospital by the Orbis. They are doing that project in our hospital, and that actually we are now just taken the fellows for it. We have started taking the fellowships. This is our second year. So it's a learning process to us as well. So the aim, the same thing what you said, that is put forward by the Orbis. It is mainly aimed at the women ophthalmologists. So to make them work and learn in more comfortable manner. So they can probably come to us. They come in, if it is a 1 year fellowship, basically it is a glaucoma fellowship, what is we are offering now. So if it is a 1 year fellowship, then 6 months they come to us, and the 6 months they are supposed to be in their hospital. And in 6 months we train them here. And then in next, the 6 months they go to their hospital and we virtually train them. So basically we are, in the process of, and we are learning through it. So how it, is going to, how the fellows are trained, and are they trained in similar way what the normal fellowships, the fellows learn. So that is itself is a learning process for both us as well as Orbis. And if it shows at the end of the fellowship that yes, it is fruitful and it is useful, then probably we are planning, the Orbis is planning to extend that fellowship in other departments of our hospital also. So now that fellowship is funded.
Yeah, this is good, and probably over a few years it'll get defined, and there'll be a system in place where the training in a sandwich fellowship is as pakka as in a normal fellowship. That is very good, and so you've basically covered everything, and could you please share some information as to if young ophthalmologist from Kerala has to apply for short-term or long-term training in HV Desai, how do they go about it?
So basically, they have to go to our hospital's website, hvdh.org. So there we there go to the training part, and they have to apply online. So they have to send a mail. Okay, and whatever fellowship they are interested in, whether the short-term courses, we provide all the fellowship, both short-term and long-term in cataract in all specialties. So they have to apply online, they have to send mail, and accordingly they will get a reply. The paid fellowship, all the short-term fellowships, we take candidates, and they are taken as per the priority, the first come first serve basis. Okay. And
what is the waiting period like for a short-term fellowship as of now at present?
Sir, it is more for the cataract fellowships, more for the phaco and SICs, definitely, but not more than 3 to 4 months. Sir.
Oh, 3 to 4 months. That's good. That's good.
Monthly, basically, we take around 4 to 5 SICs training and 4 to 5 phaco emulsification training. So around 10 training, cataract training was there. So it is not more than 3 to 4 months. So if they have to just send a mail, and I think we will get back to them, and we can tell them where they can take and for the other specialties, waiting is more for the retina, because retina, but it is not more than 3 to 4 months, I will say.
Yeah, very good, ma'am. I'm really happy that you joined our program, and these many fellowships offered by your hospital. That's very good. I'm sure that this program is going to be seen for months together, and it'll be sort of a reference guide for all those kids to see what are available. And you've really beautifully explained all the facilities available there. Thanks a lot for joining us. And again, I'm Dr. Rohan should be here. Like Dr. Madan Deshpande, he talks about Dr. Madan Deshpande, and then he's in a different level. So our pronouns to him. Please convey.
Definitely, I will give you a message to him, sir. No, definitely.
Okay. Thank you, ma'am. Thank you.
Thanks. Sir.
Next we have. I basically did my post graduation from RP Center, and I became an ophthalmologist because of RP Center. But I became a surgeon just because of Shankar hospitals and my guru there, Dr. J.K. Reddy. See, if I can do 800 to 900 FICOs in a month, it's just because of Shankar hospitals, and it's really grown from the stage where I was there in the early 2000 when we had only our Coimbatore branch. From there, now it has become the largest chain of charitable eye hospitals in India. Now we are opening one in Varanasi, then another one in Hyderabad. We have centers in Bangalore, and all across India. This is a hospital which is growing day by day, and along with that, it's not just the charitable services and the number of surgeries that is being done. Along with that, we have the Shankar Academy, where different training programs are there. We have Dr. Saptagirish with us, who is in charge of the training programs of Shankara Eye hospitals across India. Dr. Saptagirish, you're there? Dr. Saptagirish?
Good evening, sir. This is Dr. Archana.
Yeah, Dr. Archana.
Yes, sir will be joining shortly, sir.
No issues. Archana, you have a presentation, right?
Yes. Shall I share my screen?
Yeah. We'll start with your presentation. I've already introduced Shankara. So, okay. You can make it full screen.
Yes, sir. Okay. Good evening, everyone. So I'm Dr. Archana Bhatt, IOL Fellow in Shankara, Bangalore. I'll be speaking about small incision cataract surgery, the Shankara way. So here in the Gift of Vision outreach camps, we screen for patients for cataract, and also we check their systemic parameters. And once they are medically fit, we take them to the base hospital and for surgery workup. So pre-op evaluation of slit lamp examination, fundus, and ultrasound biometry is done. And once the patients are ocularly and medically fit, they are posted for surgery. So the eye for surgery is marked, and peribulbar block is given with lignocaine and Hyalase. So the eye is painted with 10% povidone iodine, and disposable drape is used. The surgeons sit on the temporal side. Here we prefer temporal section because majority of our patients are in the elderly age group, and this counterbalances the against rule astigmatism. Also, it is more convenient in patients with deep set eyes, and also in patients with filtering blebs, or even in case if the patient requires a trap surgery in future. The only exceptions are one-night patients and young patients who undergo surgery by the superior section. So this is a video. So temporal section SICS, peritomy is done to expose 3 to 4 clock hours of bare sclera, and cautery is done if necessary. So using a crescent blade or any other blade, a small scleral groove is fashioned. So this gives us a hold on the globe. So we can stabilize the globe when we make the incision. So using a 15 blade or a crescent blade, 6 to 7 mm incision is made temporally. and the sclerocorneal tunnel is fashioned. So the heel of the blade is placed on the sclera, and along the contour of the globe, the sclerocorneal tunnel is made to prevent any premature entry or buttonholing. So roughly the width of the tunnel is around 3 mm. So the side put is made about 90 degrees from the main wound. The anterior capsule is stained with trypan blue dye under air bubble. This air bubble prevents the staining of the endothelium, and adequate time is given for the staining of the anterior capsule. And after that, it is washed using normal saline. So using dispersive OPD, the air bubble is removed and AC is formed. Cornea is coated with OPD, and using a 26 gauge bend cystitome, continuous curvilinear capsular excess is performed. So in case of beginners especially, this approach through the side port serves well because it prevents the shallowing of the AC and also the rhexis run away. So once the rhexis is completed, again AC can be made tight using OVD, and AC entry is done using keratome and extended. So cortical cleaving hydrodissection is done by lifting the anterior capsule, and you should be able to see a nice wave under the nucleus, and the nucleus mobility is confirmed. So once you're sure that the nucleus is freely mobile, then under visco cover, using a Sinski hook, you can just gently lift one pole of the nucleus and cartwheel it out of the bag into the AC. Once it is completely into the AC, visco is injected below and above the nucleus to protect the endothelium, and using a wire vectis, the nucleus is delivered out. Using Simcoe's irrigating aspirating cannula, cortical wash is given. Again, the side port approach is helpful for beginners especially because the PC will not come in contact with the aspirating cannula frequently. Most of the cortex can be aspirated through this approach. For the sub-side port cortex, you can approach via the main port. Once the cortical wash is done, bag is inflated using OVD, and rigid PMMA lens is inserted. Once the leading haptic and optic is inserted into the bag, the trailing haptic can be dialed in. After the IOL insertion, thorough visco wash is given. So we're really thought to give a good visco wash to prevent any post-op IOP spikes or edema. So take your time to give good visco wash. After that, the side port is hydrated and AC is well formed, and wound integrity is checked. Once we make sure that there is no wound leak and AC is well formed, then the peritomy can be closed using bipolar cautery. This is very important in case of temporal sections, that the wound is well covered by conjunctiva to prevent any infection. So in Shankara, we follow another method of tunnel creation, that is using a razor blade. So this is another video. This is by an experienced consultant. So after peritomy and gentle cautery, only the bleeders are cauterized, excessive cautery is avoided. This razor blade is used to make a scleral groove and also the incision. So the sclerocorneal tunnel also is made using the same blade. So once the plane is found, the tunnel is created and AC entry is also made using the same blade. Here no side port is created. So again, anterior capsule is stained under the air bubble. and washed. And OVD is used to form the anterior chamber, and the rhexis is made. Here we have to be careful that we do not apply much pressure on the posterior lip to prevent the shallowing of the AC and the rhexis runoff. So here no side port is created. All the manipulations are done through the main wound. Hydrodissection is performed. AC is made taut with visco before extending the tunnel to its entire length. Once the complete AC entry is done, again nucleus, one pole is gently lifted out of the capsular bag and cartwheeled out into the AC. Under the visco cover, using the wire vectors and sandwich technique, the nucleus is delivered out. Cortical wash is done to the main wound. Here again, the tenting of the anterior lip will not cause any shallowing, but any pressure on the posterior lip will cause shallowing. Here we can see the integrity of the wound, that there is no shallowing of the AC and there is no iris collapse. So once the cortical wash is completed, the bag is inflated with OVD and a rigid PMMA lens is inserted into the bag. And a good visco wash is given using simple cannula. So AC is well formed throughout the procedure. Wound integrity and any wound leak is checked for before closing the peritomy. The peritomy is closed and the wound is covered well with bipolar cautery. And this procedure works well in experienced hands. So there's also a paper published in the Kerala Journal of Ophthalmology in 2020 comparing the scleral tunnel constructed with crescent with that versus razor blade. So here 100 cases were evaluated, 50 underwent surgery with crescent and 50 with razor blade. So here you can see that using one razor blade, it can be used in 4 surgeries. So the one edge of the blade is broken using the Castroviejo blade breaker and holder, and using the same blade holder, the surgery is performed. So it's quite economical in a high volume setup like ours, but also it works well in experienced hands. So this is an ASOCT. On the left hand side, it shows the picture with tunnel constructed using a crescent, and on the right hand side, that constructed using a razor blade. Though the inner lip is a little deeper in that constructed using a razor blade, the wound integrity was comparable in both. So again, here in the beginning, we are taught to use 15 number blade, and then once you're comfortable with that, you can go ahead with crescent and then the razor blade. Thank you.
Yeah, Dr. Saptagirish is here.
Yes.
Yeah.
Hi, Ashwini.
Hi.
Hi. Thanks, Dr. Archana, for just showing us around. And let's put this down a little bit. Yeah. Thank you. I'll just be sharing my my presentation. Just 1 minute. So is my screen visible, Srini?
Yes, it is visible. It is visible.
Good evening, and I'm Dr. Saptagirish. I'm the Dean of the Shankar Academy of Vision, and it's based out of Bangalore. So I will just be talking about the fellowship that's available at Shankara Hospitals. So as an introduction, the Shankara Academy of Vision is basically the academic wing of Shankara Hospitals. And we have a presence of at about 11 hospitals across the country right now. And we'll be opening the 12th one right subsequently next month, March. We're opening the 12th, and then the 13th will be subsequent next year. So we were chartered in the year 2014 with the prime aim of training doctors and other paramedical staff. So we have long-term courses which we started with for vision care technicians since 2000. In optometrists, when we started with our optometry colleges in 2010. DNB ophthalmology has been with us since 1996. And the main forte of our entire training program has been the ophthalmic fellowship programs and also our optometry fellowship programs in various subspecialties. And since 2014, we've trained about 300 fellows who've done more than about 4 lakh surgeries till date and still ticking. And the subspecialties offered are wide range from cataract to corneal refractive, glaucoma, pediatric ophthalmology, orbit ophthalmoplasty, medical retina with cataract and vitreoretinal. So how our process goes is that after our initial advertisements that we put up on our websites, and it's not of hearsay, and people also get to know us from our WhatsApp and Facebook and Twitter channels. And once they get to know it, they apply for it, and we have a fixed dates for which the interview process starts. So the process is like they all have a written exam, and after the written exam, it's a multiple choice question. And after the written exam, they all undergo an interview by our consultant panel, which consists of experts from across the country. And once they're done, a merit list is drawn up. And depending on the merit list, the candidates come and they choose the specialty and also the area where they want to do it. Like they may choose Bengaluru or Coimbatore or Kanpur, Ludhiana, Jaipur, whichever place they want to be. And they take up the fellowship or whatever fellowship is of their interest. And at the same time, we also have waiting lists where some candidates we've seen that they're not able to join after taking the initial one. So we call them the waiting list in order. That is how the selection committee has been. Of course, we also have a small session with the in-house psychoanalyst or a psychologist. So what the psychologist does is they just give an insight about every candidate that is being interviewed. The idea is that it's not to actually mark anyone on this assessment, but it's just to have a short insight about the candidate, about their abilities, about their expectations, and see if it matches with what we are. And so they always tell us that, this candidate is wanting this, and so we can help them with that, and that sort of a thing. So it gives us a better understanding of the candidate, and it makes the journey for the candidate also much more smoother when they are immersed with the fellowship. And once they join us the fellowship, we have a short induction program that they join us. And we have a structured dynamic pedagogy. Why I say structured dynamic is because before 2014 also we were having a fellowship program in multi-specialties like IOL or cornea, but it was not following any pattern. So every center would have their own pattern, their own way of doing the fellowships. So we got a particular structure which was rolled across the country, and everybody was following that. And then we had, the way I say it's dynamic is because, just one minute. The reason why I say dynamic is because it is, we incorporate changes depending on what the fellow feedback has been from. Like, for example, the way I look at the program right now, it is far different from what we started in 2014. So from every batch of fellows which pass out from the organization, they give us a good feedback about the pros and cons of what has happened in the stay over here. And we try to modify and incorporate the changes that they've suggested. So our program keeps changing with the demands of the time, because 2014 to now, it's almost like 8-9 years, and the demands have changed from the fellowship of what it was in 2014 to what it is now. So we try to incorporate the more modern methods. And at the same time, we also try to look at other organizations and across the world and try to put in something which is being followed in a much more modern way and try to make it much more exciting. So coming to our cataract fellowship, it's an 18 months fellowship for all people who finished the 3 years PG program, like either MS or DND. And for those who are joining after the DO, it is a 24 months fellowship. And yes, we do pay a stipend for a fixed amount of 35,000. But that's the maximum that we can pay now. But we have to see that later on if it's required to be revised. So we have a structured, graded approach to our training, in the sense that we treat every fellow as an individual, and they're given small tasks to perform. Like first they will be observing the blocks how they're given, and then they may start doing maybe a little conjunctival openings and then making tunnels. And once they're confident in that, then they go to the next step. So it's a very stepwise approach in which they go. And once the person is confident that they're able to handle a complete case, they're given that and they keep on operating that. And we have a mentorship program in the sense that every fellow, irrespective of what fellowship they take, they will have a mentor. And the mentor will be with them for their 18 months of duration when they are here with us. And those who are in subspecialty, let's say for glaucoma or cornea, they will have both cornea specialty as well as cataract. So they will have two mentors, one for the cataract training and one for the cornea training. That is to break up the monotony and also to prevent any bias in training. And this is a graded skill transfer where the skill is monitored in a specific way. I'll just come to that. So that's exactly what I was talking about. So we run through the Oscar programs, the Oscar sheets, and also the mini CX sheets. But these are nothing but evaluation sheets which every fellow fills up at a quarterly time, every 3 months. And the mentor actually gives them a grading. And how it is done is that the mentor will step into the theater and say, I'm taking a small Oscar score for you for, let's say, cataract. And the fellow says, yes, it's a good time to do it. And they both come to an agreement of which case it's going to be done. And they're marked in all the points which is there in the ICU Oscar sheet. And then the mini CX is what is called a mini clinical evaluation form, where what happens is between the fellow and the mentor, they take a decision whether they want to have the exam on a clinical situation or a surgical situation or an admin situation. And they decide the time between themselves. Usually it's a fellow who tells that I want to take this particular session, or they say that I've read the first 4 chapters of a book. You examine on the first 4 chapters of the book. And then time is decided and they both sit together and the exam starts. And then they are marked on a lot of factors. There are about 10 points on which they are marked. And at the end of the exam, one of the examinee gives their feedback. And the one who's got examined also gives a feedback saying that whether they like the exam pattern or not. And once that is done, we keep it in every individual's records, and we see that they're constantly making an improvement in the mini CX and also the Oscar. So this is a gross way in which we can monitor them. And another way is we also have a routine evaluation and feedback, as I mentioned, every 3 months. At the same time, the mentor gives a feedback on their individual performance. And I also take a feedback from every fellow so that the bias is prevented. And there will always be issues between them or between organizations or any small issues which are there, and they are ironed out together in the subsequent sessions or at the same time itself. And there's another way that we constantly try to monitor is what we have as an archival of surgeries. For every surgery that is being done, whether it's the community side or the paying side, across the country, every microscope is connected in the sense that they are connected to a computer in Bangalore, where I get to see every surgery being done across the country by anybody. Mostly it's the fellows who I try to monitor and see how they're surgically performing and handling the complications. And anytime I see a red flag, I can approach the mentor or approach the fellow and say that, okay, you're having this issues, let us sit together and sort it out. And that's how it is done. So this gives a confidence to the fellow also, in the sense that they understand that mistakes are a part of training and they don't have to be taken too hard. In case the mentor takes it too hard on themselves, then we try to intervene and try to iron out the rough edges that happen. So this is how we've been doing for the past 5 years now, because we started pre-COVID time, and it looks very successful, and both fellows and mentors are quite happy with this. Now, as we have an entry process, we also do have an exit process, where every fellow is supposed to submit a digital logbook of their entire performance in Shankara, and they're also supposed to do a peer-reviewed publication in an index journal. That is mandatory for them to be certified that they've completed the fellowship. And they all have a written exam in the specialty, whether it's IOL or cornea or refractive. They will have a written exam. It's a 3 hours duration exam, and all my fellows hate me that day for it. And we don't spare them with that. We also have a Viva exam. And the Viva exam is taken not by our faculty or nobody from Shankara. So we have people coming from across the country. Like in this picture, we have Dr. Rajesh Sinha, who's come from all the way from Ames to take the exam for the cornea exit exam. And this exam going on where they give, it's just like a very highly, like almost like a fellowship F&B exam, which happens. And once the exam is done, the examiners give their remarks and they give their marks, whether they pass or fail. And we combine both the written exam and the Viva exam. And then they say, yes, you passed your fellowship. Now, there's a small caveat to this in the sense that the fellowship for cataract, since they don't have a Viva like this, they actually have to perform a live surgery. So the exam that we had, Dr. Harsha from Jaipur, he came as the external examiner to examine all our fellows at Jaipur. And they all got to perform 2 SICS surgeries, and he was rating their performance on the Oscar chart, and then he said whether they passed or failed, and apparently they've all done quite well. So that is how our exit exam is in process. And after the exit exam, it's time for celebration when they get certified. So we have a convocation for every batch that passes out, and that's all the ones in the black with the caps are all our fellows who just graduated. The ones in blue are the faculty, and the ones in red are the office bearers. And the one in the blue central one is the guest of honor. And we also have a best fellowship award, which is awarded to the fellow who's excelled in that small duration of time, like whether it's surgeries or clinics or publication, their relationship with others, soft skills, everything is taken into consideration. And the marks are given across the units. And we decide who's the best fellow of the entire batch, and they're given a small medal with that. So that's how our entire process of our fellowship is. And these are some of our, we also have an alumnus, which is quite active and growing now. And these are the 2 surgeons who've been in an alumnus from Coimbatore. And he's Dr. Ameya, who did his cornea fellowship. And he did a huge number of surgeries, close to 3,500 in his DNB itself. And in his fellowship, he did close to about 5,000 cataract surgeries. And he's cornea trained, and he's got his own clinical practice. And he's Dr. Ameya. You see him operating here. He's the chief medical officer at our Jaipur unit. And he's doing a lot of surgeries, and he's a very competent surgeon, one of the best surgeons that we have right now. So that's all about our fellowship, and I'm absolutely free to take any questions. Thank you once again, Srini.
Thank you, Dr. Saptagirish. Can you please unshare? Yeah, I said in the introduction of Shankara Eye Hospitals at the beginning of the Shankara session, like this is a hospital that's bringing out a lot of well-trained persons. I'm an alumnus, but I got much more number of surgeries. Probably I did about 20,000 or more in my 2.5-3 years in Shankara. But it was not that structured at that time. But though we were really well trained by Dr. J.K. Reddy, and also so everything was going well then, and now with the structures program definitely is. So I have a few queries. Like, do you have short-term programs there?
Yes, yes, we do have some short-term programs. We have one in phaco emulsification. It's a 1-month program which is run in Coimbatore. It's run in Bangalore, Guntur, and Shimoga. So the candidates, the fellows who are interested can apply, and we run through the CVs. Since it's a very short-term phaco program, we expect that the fellows are applying for phaco should have done at least about 400 SICs wherever they are applying from, because it's very difficult to teach them the main handling, because phaco requires some amount of basic skills which is already there, and then you build up on that. That is one requisite that we look at before taking any candidate for phaco fellowship.
And how do they apply?
They apply online through our portal, through the shankara.com portal. There's an active page over there for phaco emulsification applications. So they just log in and they apply. It's online. They can download the application form, or otherwise they can just call up our HR, Mrs. Radhika, or they can send an email to me or Dr. Kaushik, that's director.sav@shankara.com. And we reply back to them, and then we look through the CV and see if they're actually whether they're able to complete the program or not in the first place. And then they take it on board, and it's a paid fellowship. Like in Bangalore, they may have to pay close to about 9,000 for 1 month. And of course, we provide they can stay in our hospital. We have some rooms in our hospital where the candidates can stay. And it's a 1-month program. And they do get approximately about 25 surgeries in that 1 month.
Yeah,
there are people who have done even 50, 60 surgeries in that 1 month, but that depends on person to person.
When it's a very structured fellowship program where you have a convocation and everything, but is it recognized by any university as such, or
no, Srini, we don't have any university recognition. Our Vitretina fellowship was earlier certified by the Rajiv Gandhi University of Health Sciences in Bangalore, but now we are not with them anymore. So we have our own structure and our own curriculum. We found some hurdles when we were with them, so we withdrew our application with our GOGs. No, we don't have any university application.
Okay. Thanks a lot, Dr. Saptagirish. Shankar is doing really well, and it was a comprehensive presentation. You've explained everything, and now we will move on to another huge group.
Thank you, Srini. Thank you.
Yeah, thank you. Please stay on. Let's listen to what the great people from Chithrakoot are doing, the Sadguru hospital, and see if Shankara is the largest growing charitable hospital group in India. It's this is a hospital which is probably as a single hospital doing the largest number of cataracts. And so I was talking to Dr. Elijah Jain, and he was telling they have their different ways of making things work. They have beautiful modular theaters, and they have their way in making surgeries cost effective. Like they have their vendors who make all the 3 blades together in a single packet and all. And we have Dr. Alok and Dr. Rajesh Joshi, who'll be enlightening us regarding how Sadguru works. And welcome you both. Dr. Alok, please start your presentation.
Thank you so much. And I'll share my screen. Is my screen visible, sir?
screen is visible. Please make it full screen.
Yes, I'll do it. Is it now okay?
Yeah. Now it is fine.
And I hope I am audible clearly.
Yeah.
There is some issue with the network in Chithrakoot.
Okay.
So 2.4 crore patients or lives that we have touched, 28 lakh surgeries, out of which nearly 4 lakhs specialty surgery. And on behalf of probably the largest tertiary rural eye care center in India, I and myself, Dr. Alok, and my colleague Rajesh Joshi, who is head of the cataract services over here, we take this opportunity to thank you, sir, for giving us this time to share the work that we do here and the training that we provide to our center at Chithrakoot. So in next few slides, or in next 20 minutes, what I will be telling all the participants about what are the different training programs that we are running, what is the structure of the program, what they should expect of when they take up fellowship at Chithrakoot. And we have a small video which Dr. Rajesh would be sharing how the cataract training is done here and how we perform our MSIS. So I'll start. So we had a very humble beginning, and this was in 1950 when the first eye camp was organized at Chithrakoot by Paranpujya Gurudev. And you can imagine at that point, Chithrakoot was like a jungle. There was no electricity, no roads, no water supply. And even then, about 950 surgeries were performed. From then to now, we are doing almost 1 million. We are serving almost 1 million patients every year, doing about 1 lakh surgeries, more than 1 lakh surgery every year. So these, you can see from this 2 graph or map, from the area where we are serving predominantly, it is the central area, which like 50% of our patients are from Bihar and 50% from Madhya Pradesh. And that part of Madhya Pradesh and Uttar Pradesh where the services are more or less non-existent. So we are trying to give reach out to people who probably have nowhere to go. Now, when we think of, or when most of us think of a charitable organization, they think of high quality, quantity surgeries, but the quality is always a question. And that has always been in our mind. And so at Chithrakoot, what we provide is an affordable quality eye care. So the patients can afford, at the same time, the quality is not compromised. So no compromise on quality is the thing that we always highlight. So we have a structure of art infrastructure at our campus. We have 26 model rotis, which are well equipped with all the modern machines and microscopes and whatever a modern day ophthalmologist can dream of, he will have. We have 5 specialty clinics, including cornea, glaucoma, oculoplasty and ocular oncology, pediatric ophthalmology, and retina. But what is most important, which we believe, is the team that works. You can create infrastructure, but unless until you have a dedicated team, you will not be successful. So as far as teaching and training goes, we have DNB seats. We have 10 seats in DNB. We also have ICO fellowship program through which we train fellows from across the globe. We have short-term training in cataract, medical retina, and glaucoma, which are about a month, 1 month and 2 month courses, 1 month course in retina and 2 month course in medical, 1 month course in cataract and 2 months course in medical retina and glaucoma. And these are paid courses. But what is our focus and what is very important is the long-term fellowship programs that we have in all our specialties, including cataract and eye. So the long-term fellowship program is of 2 years duration in vitreoretina and uvea and 3 years duration in other specialty. The number of seats that we take per year is around is 4 in vitreoretina, 10 in cornea, 8 in oculoplasty, 8 in pediatrics, 8 in glaucoma, and 10 in cataract and eye. And the admission process is through a written test and interview. And you take a year and the July. So how can you apply? A website and go to this. The website is of our trust. You can go to SNC and you go to the training program, and you then have to go to clinical training, and you then click on any of the program that you want to go for, and then you can download the application form, and the application form has to be filled up and sent to this email ID which I have shared. If you need more details on the program, you can always contact my PA on this number. So I'll just go through the highlights of some of the fellowship programs that we have. The cataract and IOL, starting from cataract and IOL, this is a 3 years program, and where they get to learn, they get to see a lot of patients in general OPD, but they also get a rotational posting, 2 months rotational posting in all the subspecialty, which is hands-on with limited exposure to specialty cases. Like if they come to retina, they would be given retinal lasers and all. If they go to oculoplastics, they would be doing DCRs and some of the oculoplastic surgeries. If they go to cornea, they would be exposed to corneal tear and pterygium. So we try to give them some basic specialty surgeries as well. And they also do advanced cataract surgical training, which Dr. Rajesh would be highlighting on further, where they get to do, they get to operate on higher end machines. They get to do premium IOLs and other cataracts, and handle complex cataract scenarios. Most of the fellows, when they finish, by the time they finish their surgeries, they have their fellowship, they have probably done more than 8,000 surgeries. And we feel that they are competent enough to handle any kind of cataract scenarios. Coming to cornea, we have a 3 years cornea fellowship. Here also we rotate them to other specialty, but usually there is no hands-on. They also get to do a lot of adult cataract surgeries, apart from all the cornea procedures that they would learn in the 3 years time. Similarly, in pediatric ophthalmology, the fellowship is of 3 years. And again, they get to do a lot of adult cataracts. Apart from that, in pediatric ophthalmology, they also get an exposure of pediatric glaucoma, because pediatric glaucoma is, in our institution, is part of pediatric ophthalmology and strabismus department. And they get limited exposure to pediatric oculoplastics as well. Coming to vitreoretina and uveitis, it's the only fellowship which doesn't have adult cataracts. And it's a 2 years program. And you get to do all the simple and complex cases that we come across in vitreoretina. Apart from that, you have a huge exposure. We see a lot of uveitis patients, so you have a huge exposure to uveitis as well. The oculoplasty department, apart from oculoplasty, they also do ocular oncology and ocular aesthetics. So they have a good exposure to ocular oncology and ocular aesthetics. And as they do a huge volume of adult cataracts as well. Glaucoma is a 3 years program, and we have, again, they do a lot of adult cataracts, and they are exposed to all kind of glaucoma, OPD and surgical procedures. So these are the entitlements that they have during their fellowship program. The stipend is 35,000 for the first year, 45,000 per month for the second year, and 65,000 per month for the third year. They get a accommodation which is shared, and at times we also provide them with family accommodation if it's available. The accommodation is within the campus in the safe and secured environment of the campus. They get 20 days paid leave every year. They can eligible to go for 2 national conferences per year, provided they have oral presentations. They have an health insurance and coverage, and we also provide them with recreational activity. Like we have this beautiful clubhouse with gym, swimming pool, and badminton court, which they can utilize during their leisure time. So now I'll hand over to Dr. Rajesh Joshi, who would be taking you through our cataract surgical training program.
So good evening all, and thank you for the opportunity given to detail our fellowship programs. So I'll be little highlighting our cataract surgical training program. When they join us in the first month, we get them into induction and orientation programs to the protocols and workflow of OPD, wards, OT, and CSSD. And second month onwards, we get them enrolled into our surgical program. Surgical training, most of the fellows, they have had some exposure of surgical training in their residency programs. So most of them have good head-eye coordination with microscope. They are used to do this. They have already sutured something, but few of them who has not been exposed, we get them into wet lab to do some suturing practice and hand-eye coordination. So for initial 20 cases, we give them supervised surgeries. The trainers are of course consultants, and after getting them 20 cases, we feel these cases are sufficient for majority of them, so that thereafter we can let them free to do surgeries with clear instructions. And the instructions are what that for initial few hundred cases, they should go with easygoing cases, and they must seek help SOS from senior fellows and consultants, and not do experiment. If surgical course is not going normal, then just call the consultants or senior fellows for help. They are bound to report any interrupt complications or any post-operative mishaps to the consultants. We let them record their surgeries regularly and get it reviewed by consultants so that they can discuss what the areas they are weak in or they are getting problems, so they can discuss with consultants and rectify their surgical steps. We tell them to step up to difficult cases gradually as per protocol, or after getting their videos reviewed and consultants' personalized inputs, they can step up their difficult cases. At the end of month, we generate this reports regarding complication of each and every surgeon from the consultants to the fellows, and we just highlight if it is more than some 3%. So we call them who are having more complications. We call them that what area they are having problem with. Again, the same kind of video reviews and inputs. So after 18 months of fellows, we start FECO training. We enroll them for FECO training. So that FECO training, it's very well structured FECO development program that is in collaboration with Alcon. So Alcon, they provide us with a FECO development specialist from their team who is expert in the machines, the machine parameters and basic surgical steps also. So they do a pre-workup with all the fellows even before 1 or 2 months prior to the actual training of FECO. So then video reviews are done by consultant before starting the FECO. They go to wet lab and there they get support of this FECO development specialist from Alcon. And when actual training starts, so each trainee get training for a week. So we give them cases every morning and evening sessions. So 2 cases per day. So overall 12 cases they do under supervision. And by that time, they get confident in doing, most of them get confident in doing independent phaco surgeries. Then further they are let independent for doing phaco surgeries. Some few of may get some extended support depending on the skills. For upgradation of skills in final year, we conduct few workshops, for example, in anterior vitrectomy or CTR implantation using wet labs and the resources available in the wet lab. So after doing these, they are gradually given cases, the complicated cases by themselves, and by the end of fellowship, they are very competent. And in between also in the third year, in third year, fellows are quite competent to handle complications of their junior fellows. So I will be sharing one of videos of our preferred MSIS technique at our center. So we usually do a superior SICS, making side port first. And we prefer to make conjunctival flap and a frown incision. We avoid cautery and just we do a little bit blanching, mechanical blanching of the blood vessels by motions of this 50 number blade, and then using crescent we make a tunnel around 4 to 4 by 6 mm. Keratomy is used to make a self-sealing internal incision. And we use utrata. Right from the beginning, we train them with utrata forceps for making rexes. And after doing hydrodissection, just dial out the lens with the pressure of either cannula or Sinski itself, and using irrigating vectors for the ductus delivery. And for this irrigation aspiration, we prefer to do it for side ports, so as to maintain the advantage of post-chamber surgery. And for AVL implantation, in a viscofill environment, use bimanual technique, pushing the lens inside with non-dominant end, and with dominant end, we pull it into the bag. So after thorough visco wash, the chamber is sealed using hydration of side port, and a dexamethasone injection is given under flap to seal the tunnel. So why the fellow should choose SNZ1? Because there is huge exposure, as the number themselves spoke, as Dr. Alok has shown, in terms of clinical as well as surgical exposure. The good academic environment, mentorship is strong here, and above all, it's satisfaction of giving back to society what you are getting from. Thank you very much.
Hello. Hello. Yeah. Thank you, Dr. Rajesh, and thank you, Dr. Alok. Wonderful presentation. Really impressed by the sort of work that you're doing there. I mean, you told about that Alcon fellowship. So all the short-term phaco fellowships are through Alcon, is it?
It is only for our in-house fellows. The Alcon, they have a different, like, we take candidates who are enrolled through Alcon, but all our in-house long-term fellows, they go through the Alcon PD program as well.
Okay. In addition to that, Alcon will get their trainees also to your hospital,
yes.
Is it?
Yes. Yes.
Okay. And how frequently do you take that?
So Alcon PD program, like usually we take one candidate per month through the PD program.
So other than that, other than the Alcon program, you don't you don't have your own short-term fellowship program, right?
We don't have for cataract at present. We used to have it in past, but because it's too much of training for our consultants, because most of these trainings are being imparted by the senior most faculty. So we have stopped the short-term cataract program as such. It is only through the ALCON PD program that they can come.
Okay, it's basically the strain on the consultants is what you prevented. What prevented you from continuing?
Yes, sir. Yes, sir.
Okay. And so the trainees that come through ALCON, they select or you select?
They select, but they send us their videos, and it is only after our consultant they feel that the candidate is good enough for taking up the PD program. Only then they are enrolled into the PD program. Even the external candidates. So they have to send. They have to send the initially the PD PDS, the support team. They will send a video to our head of like Dr. Rajesh. He would review the video, and only if we find that the candidate is good enough for the phaco training, they are enrolled.
Okay, fine. And see, I can see that the duration, the IOL fellowship duration is 3 years, right?
All fellowships except for retina is of 3 years.
Okay. Isn't it a bit longer than the fellowships in other institutes? And what is the reason for that?
No, so actually LBPI also has a three years comprehensive fellowship program. So it is very similar to LVPI, because we are giving them a huge hands-on training on cataracts. And at times, you know, if we give them only specialty training, their cataract training lags behind. So we kind of try to make a good combination of specialty as well as cataract training. So that's why we have extended it to
how do they get to choose that specialty?
So it is based on interviews. So what we generally when we have these applications for our fellowship programs, we ask them to mention their preferred specialty. So based on the preferred specialty, we conduct interviews separately. Like those who have applied for cornea would be interviewed for cornea, retina separately, pediatric and others separately. Once we have conducted the interviews and we have the seats filled up, if there are vacancies available, then we offer them to all others who didn't get, say, their preferred specialty. We ask them whether they are willing to take up any other specialty, or that's next preference at Chithrakoot. Like if a person who wants to do an anterior segment fellowship doesn't get cornea, but his second preference is glaucoma, then we might offer if we have a vacancy in glaucoma.
Okay, got it. And see, what percentage of your fellows do prefer to stay back?
That's a good question, and it's in most of the departments, it's about 50%.
Oh, that's a very healthy.
Because that's and probably our main focus is to provide them with good work environment as well as post-work environment. You can
no. Why I ask this question is to just assess how happy your fellows are. They seem to be pretty happy there. Okay, that's great to hear. And if anyone on the panel has any questions to ask to Dr. Alok or Dr. Rajesh. So it was a wonderful presentation, Dr. Alok and Dr. Rajesh. Thanks a lot for joining. It was.
Thank you for the invite.
Yeah, and now, I mean, if you see, this is another great great institution, which I have always been looking forward to having some association with in KSOS, and I got this chance, and I for this program I asked Dr. Rohit Shetty if we can have a presentation from them. He said Dr. Lubna is our most popular, the best teacher here, and she'll take care of the presentation. And see, as you all know, Nethralaya is doing world standard work, not only in the surgical specialty, also in research, and one of the very few institutes in India which is doing world-class research. And but today our focus will be on surgical training, as I've explained throughout these sessions. Our target are the final year PGs or those in the early stages of the career. And like in our session yesterday, Dr. Paneerselvam, who is a very senior trainer, passionate trainer, his assessment less than 10% of the PG training is giving enough surgical training in their institutions, and so there, that is where the fellowship comes, and all these institutions are doing a great work, and especially Narayana Nethralaya. I request Dr. Lubna to take over from here and have the presentation on Narayana Nethralaya.
Good evening, sir. Am I audible, sir?
Yeah, you are.
I'll just share my presentation. Is it visible, sir?
Yeah, it's visible now. Please make it full screen, and that'll be good. Yeah, it didn't come full screen.
At the outset,
And now it's fine. Yeah, good.
At the outset, I would like to thank Dr. Sri making this webinar, bringing this webinar together, because I think it's informative to all our young aspirant surgeons. So, as per Dr. Srini's instructions, I will be speaking on the FECO fellowships available with Narayana. Of Narayana Nethralaya is spans over not only these 4 centers but beyond. We are an institute which is more than 3 decades old, and it began very humbly by the vision of our chairman, that is K. Bhujam Shetty sir, and now it has been taken forward by Dr. Rohit sir and Dr. Narayana sir. And the legacy of Narayana Nethralaya spans not only into exceptional patient care, but we are heavily into continuing education and good quality education, and also translation, wherein we do research in biotechnology, genetics, in ophthalmology, and we also translate it into our practice. So it is not research just meant for publishing papers, but something which we actually bring into our practice. So coming straight to the topic for today, Narayana Nethralaya offers multiple fellowships in all specialties in ophthalmology, but specifically in phacoemulsification, we have 3 different kind of fellowships available. One is the phaco-refractive fellowship, which is for 2 years, wherein the fellow is trained in phaco surgery, cataract surgery, as well as refractive surgery. We have a cornea refractive fellowship, which is for 2 years, in which the fellow is trained in hardcore cornea, refractive surgery, and also in phacoemulsification. And we have also come up with a specialized fellowship, the core fellowship, that is an acronym for cornea refractive excellence, which again is an advanced fellowship which involves cornea, refractive, of phaco surgery, as well as we also rotate them in subspecialties for certain duration depending on their area of interest, and we also include pediatric cataracts in this. So the standard stipend is about 56,000 per month for all the fellows. The eligibility is post-graduation, that is MG, MS, G from a recognized institute, and there they have to give the evidence of satisfactory clinical and surgical exposure, especially through their logbooks. The selection process is through online application. I will be sharing the website later. There is an interview process with the consultants, senior consultants of that particular specialties, and the seats are vacant in every 6 months. So step by step, if I were to give you in a gist as to our training methodology, we give a lot of emphasis on the understanding of the basics of phaco surgery. I will be talking mainly about phaco training. So we give a lot of emphasis on understanding the basics of phaco surgery, where the fellow has to present a more practical understanding of the phaco machine, phacodynamics, kinetics, operating microscope, sterilization procedure, the surgical anatomy of the eye, and there has to be continuing wet lab and simulator exposure throughout the training. Thereafter, we have a stepwise guided hands-on surgical training under supervision. There is always a consultant on standby. The fellows are never led to be on their own. We are always monitoring them step by step, because we give a lot of emphasis on quality more than quantity. So following this, we have held discussion with each of our fellows on each of their surgeries, which are recorded on the recording system, and we work on their mistakes on the wet lab simulator regularly, along with a progressive approach in the OR as well. And finally, when we know that we are sure that the foundation steps of the phaco surgery are learned by the fellow properly, and we have full confidence in the fellow, then we move them to topical surgeries and complicated cataract surgeries. Now, yesterday, during the part 1 of the webinar, there was a beautiful presentation by the team from Aravind, where they discussed in detail regarding the simulator training, and I was very impressed by that. So I will not go into the detail, but just for your information, we have the IC surgical simulator in one of our centers, which is also the wet lab, which also has the wet lab, which is equipped by Alcon. In our another center, we are in discussion, almost finalized, the wet lab, which will be supported by Earthly. Now they are giving us a fantastic wet lab, which will just add to our armamentarium. So we are very particular about wet lab and simulator training. Our training methodology is very crisp but very simple. We begin with SICS. First, we see the basic foundation of the training with the help of a basic Oscar score. We record that. We start with SICS because we believe that many a times the complications need to be handled in phaco, need to be handled by SICS. So the knowledge in SICS is very, very important. Once as the surgeon has got the hang of incision cataract surgery, we immediately move them to phaco. We have no lag with that. And all through, right from the beginning, they assist all our senior consultants. They scrub up with our senior consultants, wherein we teach them how to load foldable IOLs. They also observe our surgeries, and while we are operating, we also brief them on certain tips and tricks. Once, how do we move them to phaco? We transition them from SICS to phaco because we sit head end for our SICS surgery. That's how we train them. When we are moving them to phaco, what we tell them to make a basic tunnel superiorly, and then they move temporally and perform, and they are trained in temporal clear corneal incision. In the initial part, they put the IOL, they come superiorly again, and they put the IOL through the superior corneal tunnel. But sooner that they learn, the nuances of phaco surgery and we are confident about it, we move them to purely temporal clear corneal phaco incision with foldable IOL implantation. Because the consultant who is the preceptor for the particular fellow is always by their side. So it's a very guarded and a very systematic approach to training. We also believe that if you cannot measure it, so we are also very particular about the ICO-Oscar scoring, which has been appreciated by all our presenters here. The training methodology also becomes a little better when you have it customized to each and every training. So like I said, we have a baseline scoring for a particular fellow because everybody comes in with a certain baseline surgical level, and then we build up on that. We are able to focus on the areas of weakness because we have a systematic ICO-Oscar scoring. So we generally see as to where the trainee is specifically erring regularly. So we pick up those areas of weakness and work on them more rather than the other parts of other steps of phaco. So this helps us to give effective skill transfer. So we can proudly say that towards the end of our phaco training fellowship, the fellow is very confidently able to do topical phaco, complicated cataract surgeries, and so on. So ICO-Oscar scoring, just to run through, is an International Council of Ophthalmology surgical competency assessment rubrics. It's a standardized and an internationally valid scoring system. The surgery is divided into parts. The first 14 are the actual surgery steps and the 15th to the 20th are global indices, which include important points like eye positioning, iris protection, and overall speed and fluidity of procedure. The ICO-Oscar score generally is from 2 to 5, 2 being novice and 5 being competent, and 0 if the step was taken over by the preceptor. Along with this, what we have introduced is we pre-operatively score the surgical case using a Najar-Awad score, in which important surgical challenges are picked upon. So if you see the scoring system on your screen, you would know that we can decide whether this particular case is suitable for a particular phaco fellow or not, depending upon the severity level. Okay. So our protocol is, first we do the pre-op scoring of the surgical case with the help of a Najar-Awad system. The phaco-emulsification training is done with the help of a supervision from a preceptor. Intraoperative steps are scored in real time using an ICO-Oscar scoring system, and thereafter case is discussed by reviewing the recorded video as early as possible after the training OT. And this is done on a one-on-one basis. And post-operative rounds are mandatory with the consultant on the first post-operative day. During those rounds, we also discuss the surgical complications which have been encountered, and it's a group discussion which also helps the other trainees learn from mistakes. So the advantages of the format that we strictly follow is that the scoring parameters do not vary because it's a standardized scoring system. The allotment cases can be done according to the score of the candidate and the preoperative score of the surgical case. The areas of improvements are very specifically targeted, so the learning curve becomes very steep and they learn faster in a shorter period of time. This also helps us avoid poor surgical outcomes, because when there is a systematic monitoring, the trainee is always aware about his or her areas of weakness, and they are able to work on them better. So they are more alert, more vigilant. And at the completion of the training, a detailed assessment, all this can be easily documented into a report, which we can always give to the next employer or next preceptor for further review. So in short, the phaco training at NN includes wet lab simulated training, hands-on phaco training, ICO scoring, poster discussion, lot of academics, and post-training support. That is, even after the fellows have left our institute, we have a lot of online portals through which and get-togethers through which we keep in touch with our fellows. And at any point of time, if they have any issue with an equipment, I also have some fellows who would call me if they've had a complication. They call me back after many years also if they have any issues to discuss, and we are always available for them. And camp duties, leaves, and emergency duty rotations are subject to patient load. So we are very flexible relating to leaves if there is a genuine reason, and camp duties are also, it depends on the number of trainees available at a particular center. So what I personally feel as, if I see as a third person, what makes the fellowship at NN a very a unique fellowship is, it's a very, very customized surgical training. It's not one size fits all for all our trainees. And we have seen people who come with very minimal surgical exposure, and they progress very well in this duration of time. So most of our fellows towards the end of fellowship are able to do topical. They get to do complicated surgeries also. We teach them how to handle non-dilating pupils, post-uveitic cataract, hard mature cataract with phaco, and high-end cataract surgeries they perform, including plaques, ICL, and foldable IOLs as a part of their refractive training as well. And they also get to handle, above all, in the refractive part of the fellowship, phaco-refractive fellowship, they get to handle the best possible platforms in phaco-refractive surgery, including performing SMILE. Of course, we are the adventurous with our fellows. We make sure they have the adequate sense of responsibility and the surgical skill to go about. But yes, if they prove their mettle, the sky is the limit for them. They also get to present in podiums in national, international, and local conferences, seminars, webinars, CMEs. We help them in their character building because they are a part of if we have our in-house meetings, which are very popular, they also are a part of the planning. They give their inputs, and they perform sometimes they conduct the whole program. So they become very confident towards the end. So it's a holistic kind of a character building exercise. So because we have a fantastic genetics genetics lab at our institute, which also dabbles in biotechnology and translational research, it is mandatory for all our fellows to be a part of a research project. And obviously through that they have publications in peer-reviewed journals, and they are always encouraged to present their work at the different conferences that I mentioned. So I feel this is something unique to Narayana. At the same time, it's not like with all the heavy work, we do not, it's all work and no play. We have the principle of work like a captain and party like a pirate. So every few weeks to months, we have small get-togethers where the fellows can get their hair down and have a good time, and they are well taken care of by the institute. If you have any further questions regarding the fellowship program, we have a very interactive website, that is www.narayana.nethralaya.org. If you go to the academic section, even regarding the various fellowship programs, I may just add that we do not have short-term fellowships for any of the subspecialties, but yes, if somebody comes or subject discusses with the management, many a times exceptions are made, but overall we have long-term programs only. So thank you very much.
Dr. Lubna, great presentation. Can you please unshare?
Yes, just a minute.
Move your cursor somewhere on the screen. It'll come.
Yes, sir.
No. Anyway, like, see, what is the reason why you're not having short-term fellowships?
Sir, 1 minute. I just stop sharing.
Yeah. Okay. So
I
like,
am able to answer that question.
no.
What I feel is somehow the training programs, if they are long term, we are able to build on the progress of the training. This is what I feel.
Yeah. That is right. Like, see, as I told you, as I told everyone who I invited, see, my one basic target are the girls who are disadvantaged because of many reasons. So like HV Desai hospital, they are having that sandwich program or something. So where it's basically aimed at these girls, and the short-term fellowship also, which it's really required because they go into some small-time practice, and once they're comfortable, they have other responsibilities also if they have to go back. So that's fine. Now, each hospital has its own policies, but so I was just asking that. And see, if these fellows want to stay back, like if you feel that they are good for your institution, so what all positions do you offer them?
So we have positions of junior consultants. They can join us as junior consultants, and I'm happy to share that many of our fellows wish to join back because of the opportunities that are given, and they join as junior consultants, and purely on merit, if their work gets better or they are able to serve the institute in a good manner, they are also promoted to consultant level.
Yeah, like say, I was talking to Dr. Tirumalesh during that midterm conference. Like, see, you can understand how happy the consultants are there. Like, you give them elements for their research work, presentations, and all. That's really wonderful. And what sort of a support do you give if they're not staying back with you and they're go out into practice? Any support system that you give them so that they are up to date and they are helped out in case of trouble and all?
Many short 1 or 2 days seminars, CMEs on refresher courses for our fellows. They are open to everyone, but and we also have a common group on WhatsApp, which we are in touch with each other. Anybody has any issue, they put on WhatsApp, and Dr. Rohit sir or anybody, any of the consultants who are able to helps out. At the same time, we have regular alumni meets wherein everybody talks about how they are doing in life, and if they want any kind of a support system, it's always there. And many a times they go out, and if they feel that they want to come back for some refresher course, sir allows them for that also. That is obviously for a shorter duration, not a full-term fellowship kind of thing. So the support system is awesome.
And what is a waiting period, like if I apply now for example FICO fellowship or retina fellowship, so what is a normal waiting period for that?
It would be around 6 months to 1 year, sir. At least 6 months.
Okay.
To 1 year. Yeah.
Okay. That's
candidates every 6 months actually. So the waiting period would be between 6 months.
True.
Especially the refractive fellowship is very sought out for. So yeah, the waiting period will be 6 months to 1 year. Please.
Okay. That's good. Very happy to learn about whatever training programs are happening in Narayana. I'm sure that it's going to be useful to all those young ophthalmologists who are listening to it. And see, they're going to keep basically they're going to compare between what is offered between these institutions, and that's basically my purpose of doing this webinar, so that they can see. That's why I'm asking you all these questions, so that they'll yeah. So thanks a lot, Dr. Lubna. As Dr. Rohit said, you are quite quite a passionate teacher, and so thanks a lot. Please stay back. We have Dr. Harishankar Nag from Sushrut Eye Hospital. See, because basically I was trying to find out regarding the training facilities available across India, because the kids in our part of the world, they restrict themselves to south of India, Arvind, Shankara, Narayana, Nethralaya, Prabha. So I just wanted to get them a feeling of idea about what is happening in rest of India. And see, I've found that this is one great institution where huge lot of work is being done, and it's Dr. Reddy Chandra Paul, who is a well-known figure in ophthalmology in India. He's the head of the institution, and he's a really prolific surgeon. And so it's one of the best eye care centers in Eastern India, and the parent branch is located in Salt Lake, Kolkatta. And we have with us Dr. Harishankar Nag, who has done his fellowship from Arvind Eye Hospital's Madurai, and since then he has been with Sushrut Eye Foundation, and see that really shows that this is an institution where good people stay back. See, I've been in Contrast Eye Hospital for more than 20 years, so I love people who stay back in an institution for long loyalty and happiness. And also, Dr. Harishankar, please take over.
Hello, sir. Can you hear me, sir?
Yeah.
First of all, warm greetings to all. Thank you, Kerala Society of Ophthalmic Surgeons, for giving us the opportunity to present a webinar on such a relevant topic. Relevant because this webinar will definitely be helpful for all our young ophthalmologists and our ophthalmologists who want to enhance their surgical skill. So in the next few minutes, I'll be describing the cataract fellowships available at our institution, and try to elaborate how we perform the training. So Sushrut Eye Foundation has been started with a vision of high volume cataract surgery and an affordable service to the community. So we started long back in 1998, and right now we have two main tertiary centers, one at Salt Lake, Kolkata, and another at Berhampur, the district of Murshidabad in West Bengal. And apart from that, we have 5 daycare centers in and around Kolkata. And we are also working with one multi-specialty hospital, the Ruby General Hospital, where we run the ophthalmology department. So the amount of work that we have been doing is here. So in the year last year and presently, we have seen around more than 4 lakh patients, including in all our centers, and we have operated more than 35,000 patients. The academic opportunities present in our institution, we have DNB in ophthalmology. We have 2 primary seats and 2 secondary seats, and recently started 2 seats for diploma in ophthalmology. So all these seats are at the Salt Lake unit. Fellowship, we have long-term fellowship in all the subspecialties apart from cataract. We have retina, glaucoma, cornea, oculoplasty, and pediatric ophthalmology. These fellowships, the duration varies from 1 year to 2 years, depending upon the specialty. These long-term fellowships have the provision of getting a stipend. The short-term fellowship courses and observerships in different subspecialties are also available. Apart from that, Sushrut is also a center for the FECO development program run by the Alcon laboratories. I have no financial interest in any of the products or companies named here. Cataract surgery for residents, how we start. Residents, definitely their aim is to clear the ophthalmology with good clinical knowledge. But we do focus that they get a good hands-on on cataract surgery, so that after 3 years or 2 years of residency, whatever period they are here, depending upon whether a primary candidate or a secondary or a diploma. So we may try to make them confident in cataract surgery. So we have designed the cataract surgery program for residents in 3 tiers, tier 1, tier 2, and tier 3. So each tier is taken for a duration of 2 weeks. Now, tier 1 is basically for the candidates of primary DNB and for diploma in ophthalmology. So tier 1 basically concentrates because they are new to ophthalmology. So we focus mainly on OR etiquettes and ethics, wet lab practice, how to scrub, how to don draping, all these things we focus on the tier 1. And then they start supervised surgery. After they have done a few surgeries and good amount of wet lab practice, we switch them to tier 2. So this again is a 2 weeks extensive course. And here they get a good number of SICS every day, at least 1 case they get. And then they start doing surgery under supervision. And once we see that they have good tissue handling and they have gained confidence in SICS, then we start the tier 3 training. So the roughly the time varies like this. For primary DNB, we try to give them the tier 1 within the first 6 months of their joining, tier 2 within the first year of their joining, and tier 3 in the second year of their joining. In diploma in ophthalmology, the same thing, we try to give tier 1 within the first 6 months, tier 2 within the first 1 year, and tier 3 in the second year. Secondary DNB candidates, since they already have the exposure to surgical field, so we try to perform the tier 1 and tier 2 within the first 6 months, and the tier 3 we give in by the end of the first year, because they will be staying here with us for a shorter time. Long-term fellowship basically has been designed keeping in mind the fact that many, apart from some places, most of the places, the residents, the amount of cataract surgery that they do, probably that is not adequate to give them the confidence to perform independent surgeries. So this has been structured with the objective that they will, after finishing this fellowship, they will be confident for independent OPD and IPD management. They'll be competent enough in handling patients, and they have the enhancement in the overall skills, clinical skills. So this fellowship is available both at the Salt Lake branch and at the Berhampur branch. We have 2 seats at the Salt Lake and 2 at the Berhampur branch. The duration of fellowship is 1 year. They get a stipend of 75,000 per month. The selection of candidates is done on a basis of a written test followed by an interview. The candidates will have to arrange their own stay. The job responsibilities overall, that what they have to do is to assist the consultants under which they are posted in the OPD and IPD. They do the most of the work in OPD and IPD. They attend OPD independently at the peripheral centers. As I said, that we have 5 in and around Kolkata, 5 daycare centers. So these fellows, once we assess that they can independently manage the OPD, we post them there at the peripheral centers. The camp section that we call the social ward, they manage the OPD independently. They do have to attend emergency duties because we have 24-hour services. So, and they have to attend and participate in seminars and CMEs both within the hospital and in the local ophthalmic forum. And they also present in state and national conferences. They do have to take classes for residents and optometrists. We have different courses in optometry also. So these fellows, long-term fellows, are expected to take classes for our residents and optometrists. The duty hour usually is from 8:30 a.m. in the morning to 5:30 p.m. Yes, they have time for recess and lunch. Emergency duty starts from 5:30 p.m. to the next day, 8:30 a.m. And leave that they get is 15 days per year. Now, we are not that strict, but for genuine reasons, that leave may be taken and that fellowship gets extended for those many days. The overall curriculum of the fellowship is they have postings in OPD, they have postings in IPD, they work as a medical officer in the ward, they are posted in the block room, they observe in the OR, they do OT as well, and they are posted in the different diagnostics also, biometry, they do independently, they are posted there also. For OPD posting, they are posted with a consultant at the main center. And as I said, that they do independent OPDs in the CAM section in the main hospital, and at the peripheral centers, again, they have to manage the OPD by themselves. And definitely, they can refer any case they feel like to the main center. And they independently have to do biometry, laser capsulotomy, and others. Surgical posting only is being done at the main center. Surgical training basically is done at 2 levels. Tier 1 we skip because these are fellows already have the residency program. So Tier 2 and Tier 3. The first 3 months we focus on the manual SICS, which is always supervised. Next 6 months, we depending upon the surgical skill attained, we give them SICS gradually. We give them independently, and we start the FECO training in the next 3 months. So that FECO training again is a supervised one. And in the last 3 months, we try to give them independent surgeries because after 1 year fellowship, we expect them to do independent cases. The routine cases, at least they should be doing independently. That much confidence definitely we want to give to every fellow. So the last month, more or less, they do independent surgeries. Apart from this long-term cataract fellowship, we also have various short-term courses and observerships. Short-term courses in cataract, which are available in our institute. One is basic SICS training. So these short-term courses basically are for those candidates who really can't afford to spend 1 long year because once we are a postgraduate, we have many other liabilities as well. So keeping that in mind, we have started these short-term training courses. So basic SICS, the objective is to give the candidate an adequate exposure to SICS. We enroll such candidates also who don't have or who have minimal exposure to cataract surgery. At least we want them that they learn the basic steps of cataract surgery of SICS. And when they go back to their places, wherever they are working with, so that they can at least start the SICS surgery. And then again, they can enhance the skill later on. The duration of the basic SICS training program is of 1 month. Then SICS skill development program. So this is for those surgeons who are already doing SICS, but they are facing challenges. They want to develop enhance their skills. They want to manage the SICS complications. So for those candidates, SICS skill development course is there. The objective of this course is skill enhancement for practicing ophthalmologists. The duration of this course is 2 weeks. We have one basic FECO training program. This is again to give adequate exposure to FECO. This course definitely will be helpful to those candidates who have access to FECO at the hospital they are working with or the place they are working with. So we expect the candidate who apply for basic FECO training to be competent in SICS, because one who is competent in SICS must be having a very good tissue handling. So we expect that these candidates are competent in SICS and they are very good at capsular access, because as we all know that capsular access is very, very important for FECO emulsification. So this course is again of 1 month duration, and we give them a good number of cases so that they become confident in FECO by the end of 1 month, by by doing somewhat around 25 to 30 cases. Phaco skill development again is for those candidates who are doing phacoemulsification and they want to enhance the skill, like somebody is doing or they are facing challenges in the phacoemulsification surgery. So for them, it is being planned, and the objective of this course is to enhance the skill of those practicing ophthalmologists. Again, we are insisting on the word practicing ophthalmologists because we want the candidate to go back after the training and keep on doing surgeries so that they can maintain whatever they have learned here. And so the duration of this phaco skill development course is again of 2 weeks. The advanced phaco skill development course is for surgeons who are competent in phacoemulsification and they want to focus on key areas of surgical skill, like somebody wants to manage hard cataract, somebody wants to do how to enhance skill in managing mature cataract, small pupil. So specific key areas we want to focus. So this advanced phaco skill development course is for 1 week. We have other short-term courses also, but they are not being done at a regular basis. Like we have astigmatism management course. So here the objective is to enhance the skill of using Torical, motivate them to use Torical. So this is again for candidates who are competent in phacoemulsification. So this is just for 3 days. We give them the basics of astigmatism, basics of calculation, power calculation, biometry. So these things, these we don't conduct regularly, but whenever we have CME in our hospital, then we conduct these programs. Similarly, anti-vitrectomy workshop we conduct once in a while. So this is again a 2-day workshop. This is structured with the idea to explain the basics of anterior limbal vitrectomy. So basically, this is a wet lab based practice where we prepare the goat's eye and we give the candidate to perform vitrectomy. So this is basically to give them the feel how to perform vitrectomy, because every cataract surgeon must be good at anterior vitrectomy. Then, as I said, we are also the Center for Alcon Phaco Development Program. Both the basic and the advanced program are being conducted at our institution. So the candidate selection for these 2 programs, the PDP programs, are being done by the Alcon representative. So the important thing for this is the candidate should have an access to the Alcon Phaco machine. And the assessment of the candidate, the recording of the video, all being done by the Alcon people. We here at Sushrut, we review the video and we give that yes, the candidate can be selected for the basic course or the advanced course. I feel there are certain challenges in when surgical training comes into concern. So surgical training, yes, the most important thing I feel is the patient safety. It's not like that somebody is learning on that eye is not important. It's not, we value each eye. So we give them the equal treatment our paying patients get. So patient safety, we keep in mind at every step of surgery, during the pre-op, post-op, every time we keep the patient safety in mind. Infrastructure, yes, we have a dedicated OR for training purpose. With all facilities available over there. Trainees expectations is again a key area to consider, because see, what I feel is surgery is basically a skill. So it might be that the surgical the learning curve may not be similar for all candidates. So training expectations should again be practical, because like it depends upon how much tissue handling do I have, how much cases I have done prior to coming to Sushrut. So training expectation has to be realistic and practical. And yes, trainer's interest and patience is again important, because if practice makes a man perfect, but perfect practice actually makes a man perfect, and that practice can come only via the trainer. So what I can say is we have a dedicated team of trainers who are really passionate for teaching, and they try to address all the key areas of the trainees. The surgical training fortunes available with us are the candidates can observe the surgeons in the operating room. We have a very good wet lab infrastructure. The resident training of the on the basis of 3 tiers we do, tier 1, tier 2, tier 3. And then the training program is basically supervised. It is being done at 1-to-1 basis. We do video discussion and we rate the video on the Oscar scoring, which is very helpful. And we insist upon the candidates to maintain a logbook. We actually maintain a digital logbook. Latter part of training, the long-term fellows, they have the opportunity to do independent surgery, and they also learn to manage complications. So this is, we have monitors in OR. So the candidate can nicely observe the senior surgeons doing surgeries. Actually, this gives them the motivation, and they can also keep on clearing their doubts and queries during the surgery. Wet lab, we have well-equipped wet lab both at the Salt Lake and the Kolkata centers. At Salt Lake, in the wet lab, we have 2 stations, one station has a Laureate machine, another one has a Legion machine, and in the Berhampur center, we have Laureate machine. We have trained ophthalmic assistants to assist our trainees in the wet lab. They are very good at making wet lab preparations, making the goat's eye. The wet lab practice, it has been insisted in every presentation that wet lab practice is very, very important for training, surgical training, because it helps us to develop the hand-eye coordination under the microscope. So the trainees can practice tunnel, they can practice rhexis, they can practice sutures in the goat's eye and the cadaver eyes. And they can also practice phaconucleus management in artificial silicone eyes. Patient screening in the remote campsite, we usually don't send the fellows for camp screening. Camp screening is basically done by our trained optometrists and vision assistants. They do exams on the torchlight, and they screen the patients for cataract. Those patients are brought to the base hospital. So every day we get 70 to 90 patients in the camp OPD of our base hospital. These patients are there seen by our fellows. We repeat the preoperative vision that is again being done by the optometrists. We do a slit lamp examination, comprehensive eye examination, both undilated and dilated. So these are the slit lamp examinations done by the fellows. Then we send the patient for biometry. BP sugar has already been done. And if the fellow feels that the case is not good for training, so then the case is a little complicated, then they send the patient to specialty clinic. Either if the patient is of suppose it's a case of general dialysis, so that is sent to the cataract clinic. If the patient is a diabetic retinopathy, they send it to the retina clinic. So we send to specialty clinic from the camp OPD itself. And case selection for the candidate is being done in the camp OPD, but we have made it mandatory for the candidate to see the case again under the slit lamp before selecting that case for surgery. And inside the OT, we give step-by-step learning. We focus on step-by-step learning under the consultant's supervision. Cases are observed and supervised with the help of side scope and the LCD monitor. Any difficult step during the surgery, the consultant intervenes and rectifies it and hands it back to the trainee again. We try to have minimal dialogue during the surgery because the patient is being operated under local anesthesia, and we video record the case for discussion in the latter part once we finish the surgery. Once the fellows are confident in surgical skills, they start getting independent cases. So the teaching goal in the OR is to learning the basic steps of cataract surgery, identifying complications, and learning to manage complications. I'd like to share one video of SICS, how we do. We usually do superior SICS. So we insist that we take on the superior rectus because the superior rectus helps in good exposure of the conjunctiva during peritomy and making the tunnel. And superior rectus is again very helpful when we take out the nucleus with the irrigating vectis. So here the conjunctival peritomy is being done. We insist to cut the T-nodes as well. So after doing conjunctival peritomy, we make a side nick so that it helps us not to extend the peritomy further. Then we do a gentle cautery. Then for SICS, we prefer to, at least for beginners, we prefer to mark the site of incision because this gives them an assessment of how much to cut when they are not using the marker. So initial few cases, we insist upon using markers. So 2 mm from limbus and 7 mm, keeping the distant limbal point in the center. They use the 15-degree blade for making a scleral incision. And using the crescent. So we first undermine the incision to get a plane in the sclera. And by wriggling movement, we try to find a plane in the cornea. While entering the cornea, try to lift the crescent little up so that following the corneal dome. Then by swiping movement, we extend the sclerocorneal dissection and make the side pocket. Similarly, the sclerocorneal dissection is done on the other side. And the side pocket is made. We make a side port, usually at 9 o'clock from the main port. We use this side port to inject trypan blue dye for better visibility of the capsule. Then inject viscoelastic to tighten the globe. Then using keratome, bevel of keratome, we enter the anterior chamber, taking care that the wound is triplanar. We extend down and then start our capsular axis. We use the bent tip cystitome for our capsular axis. Every time taking care that the axis doesn't extend. After capsular axis, warp out the little bit of viscoelastic, then do gentle hydrodissection. Tap the fluid. Again, inject viscoelastic. Use a dialer to do, we usually do mechanical pull-ups. So hydropull-ups only we do for soft cataracts. So by dialing, we prolapse the nucleus in the anterior chamber. We ensure that before delivery, we inject viscoelastic above the nucleus to protect the cornea and beneath the nucleus to push the iris and PC down. Check the patency of the irrigating vectis. Inject gently the vectis beneath the nucleus. Pull the rectus and gradually deliver the nucleus out of the bag. We inject viscoelastic to take out the epinucleus. We usually use the Simcoe cannula for our irrigation aspiration. We try not to press the wound so that the chamber is maintained. And slowly and gradually in the clockwise manner, aspirate the cortex gently. We use the side port incision to aspirate the subincisional cortex because that is the area. If we do to the main port, we have chances of precedent. So we use the side port for this. We get a nicely formed chamber, and without fear, we can aspirate the cortex. Then we inject viscoelastic. And PMML lens, we place the leading haptic inside the bag. Inject viscoelastic. And with the help of a dialer from the side port, we dial the lens in the bag. Then the visco aspiration, we take care that we remove most of the visco. Form the chamber by hydrating the side port. Remove the rectus. Cauterize down to oppose the conjunctiva. And then inject intracameral moxifloxacin. So post-op care, detailed patient counseling is done by our trained staff. Post-op checkup is done by fellows and residents. Fellows and residents have to show their cases to the consultants and getting the feedback. Any intraoperative complication cases are being followed up closely. Video discussion again is an important part of training. So we review the surgical video with the consultants. They learn to rectify mistakes and managing difficult steps. Oscar scoring is done because it is very helpful to objectively assess the progress of the candidate. And after Oscar scoring and video discussion, we set goal for the next case. We use our in-house developed digital platform for the record maintenance. So we have the digital logbook. The candidate have to fill up the pre-op and the post-op data in the digital logbook, and this is being reviewed from time to time. So this is, we are available on all social networks, Facebook, Twitter, Instagram, or sushrut36.gmail@gmail.com is our email ID. And the candidates can also call up to us. So to summarize my talk, surgical training, I feel, is a journey. It's not a one-time destination. It's not like once we have had a training and it is done for a whole time. No, it's a continuous journey. We all of us in the School of Experience are students. So we keep on learning from our mistakes, from other mistakes, by observing others, by doing surgery. So surgical training is basically a journey. Various training courses are available at our centers. Selection of a course depends upon what is the level of expertise of the candidate. I would suggest that youngsters with inadequate exposure to cataract should aim for a long-term fellowship. Thank you.
Thank you, Dr. Hari, for covering everything about training and the wonderful video that was shown. What is the waiting period for your somebody applies? How long?
Short-term courses, you mean, sir?
Yeah, short-term courses.
Short-term courses, we usually have a waiting period of 3 to 4 months.
3 to 4 months.
Yes,
okay, and at one go, how many do you take?
Oh, we take, sir, for 8 for Kolkatta Center and 4 for Berhampur Center.
Oh, so at the same time there'll be 8 people being trained.
Yes, sir. Actually, the protocol goes huge. Like, yes, sir. Yes, sir. We have a dedicated OR with 2 stations. So 2 trainers are there maintaining every time, watching the surgeries being going on. And we have divided the wet lab for the morning session and OR for the afternoon session. So 6 dedicated hours for OR training and 3 dedicated hours for wet lab training, sir, for these short-term programs.
Yeah, great work, great work. Congratulations to you, Dr. Rasi Paul, everyone in your institution, and it's a wonderful work that you're doing, and I'm sure you'll have a lot of applications for Kerala after this program. And see, we have another world-class phaco surgeon, trainer, passionate teacher with us. Because see, as I said, my focus was basically on people who can't really go for fellowship as see, I was fortunate enough to go for fellowship after I finished my training in RP Center. So I just went directly to Shankara. So there was no break as such. But now, especially for girls, it's not easy to go like that, and that's where all these short-term trainings and by the best and there can be nobody better than Dr. Deepak Megur. Just see his videos on YouTube, the teaching videos, and so that is why I know that he's busy. He operates till late night. Once I called, he was. I mean, I think I called at 9 o'clock. He's still operating. Thank you, Dr. Deepak, for sparing time for us, and just. If you can explain what all training programs you have in your institution, it'd be great.
So thank you, Srini, for the opportunity, and congratulations on on having this wonderful initiative. I think this is something which is, I think most people are wanting to know, and they're really a surgical training. There is a lot of girth now, and there's a lot of demand. Every week, at least I get 2 calls or 2 mails for training program inquiry. I think this is a wonderful initiative, what you've done. Congratulations to you.
Yeah, Dr. Deepak, my basic idea was to have a platform or a site where you can compare the fellowships in different institutions.
Yeah, that is true.
So that's and thanks a lot for all your great work.
Yours is a wonderful initiative. Actually, ours is not as big a center as like very bigger centers who presented, but we are very passionate about teaching, and whatever little we know, we would want to share. So that's the thing. And anyway, thank you for the opportunity, Srini, and I really appreciate that. So can I go through my presentation quickly?
Please.
Yeah, thank you. So let me begin with the long-term fellowship. We usually don't take many fellows, just 1 fellow a year or 1 or 2 fellows a year, and we have a stipend of about 70,000 a month. A selection is done by interview once they complete their MS or DNB, and this is usually for the fresh candidates who just finished their MS, DNB or post-graduation with SRship or without SRship. So we have, this is our the stipend is around 70K per month, and see, the ultimate goal is to refine them or make them good in cataract surgery. Apart from that, the comprehensive ophthalmology is also being taught in this, and a special emphasis on cataract surgery. We begin with manual small incision cataract surgery, then do phacoemulsification, and they get hands-on on all these 3: cataract and pterygium surgery with conjunctival graft and all. So they get hands-on training, all this, plus an overview of glaucoma surgery and other aspects. So apart from being a special emphasis on cataract surgery, they also tend to develop good overall management skills and diagnostic skills, glaucoma management, cornea, and medical retina. So ultimate goal is to produce a competent comprehensive ophthalmologist who can go and start his practice straight away. That is our goal in our training program. So usual protocol is the fellow will shadow the consultant for the first few weeks, both in OPD and OT. He takes part in the pre-operative evaluation, and he attends OT on all OT days. So he will be with the surgeon all the way. So private cases, because ours is a private hospital, so he'll be there in all OT days, observing the surgery, both pre-op evaluation and post-op evaluation. And his surgical opportunities will be on the charitable cases or the CAM cases, which will be done once in a week. So the screening will already be done by optums, and the pre-op preparation, everything will be done by them. The fellows need not go to the peripheral centers to screen them. Pre-operative evaluation is done by our fellows, and they have an opportunity to operate on one set of patients in a week. And since our fellows are very less, only one fellow is there or two fellows, most surgeries will be performed by them under direct supervision of the instructors. So they will be monitored using a high resolution videos, and their difficulties or mistakes will be identified and ironed out there. Of course, in the event of difficulties or intra-op complications, the cases will be managed by the supervising instructor. The OR facility, we have the Zeiss Lumira microscope with a high resolution camera and monitor. And of course, the phaco machines of Centurion, Legion, and Infinity. And we emphasize on observing all the steps, what they do by the instructors themselves. And we have got only two instructors, myself and my wife. So we are the instructors. Either one of us will be in the operation theater always when they are operating. So it's a one-on-one supervision for them. Video analysis will be done weekly, our cases and their cases, and each surgical step would be analyzed threadbare. Of course, we believe that, can we accelerate the learning curve? That is what is ultimate goal is. And surgical skills, I would like to divide to three factors. One would be the dexterity, that is learning the motor skills, and this is a highly individual variation. One surgeon might be picking up skills a little bit faster. Some other surgeon would take it a little bit longer, but just spending a little bit more time, you can definitely increase the dexterity. But what I would like to discuss and share with our fellows is there are a lot of secrets, and the fellow might not be the smartest person to pick up those secrets by himself. So it is upon the mentor to tell these small intricate details, which we would have taken maybe years to learn all those things. And if you can share them these secrets, the learning curve becomes expedited very fast. So you really don't have to spend 5 years to learn one small trick, like how to stabilize the globe, how to not press the main wound when you're trying to enter inside. So these are all small secrets which we can share to them immediately once we can identify what specific fault they are doing. And the most important thing which I would like to share is decision-making aspect, because I think this is what is not taught in the thing. We emphasize so much on surgical dexterity. I really don't give much emphasis on surgical dexterity. It can be, over a period of time, it can be developed. But decision-making and how do you think, that is what has to be trained to them from day one itself. So that most mishaps and complications happen not because of the lack of surgical skills, but majority of them happen because of poor decision making. So this is one aspect which is a mental aspect, not the which is related to motor skills. The mental aspect, this is what we need to train, and our emphasis is more on that aspect, so that is the reason why we believe that surgery is done with the mind and not with the hands. Unusually high amount of emphasis given on surgical hands, but I don't believe that is the fact. The fact is it is done with the mind. The surgeon has developed skill because he has analyzed so many things, he's knowledgeable, he can anticipate things, and that's the reason why some surgeons are more successful than the other, not because there's something gifted with some 14 fingers or extra stabilized hands. So this is what concept which I want to drive into my fellows and give them confidence that dexterity is not the most critical thing. Intelligence, knowledge, creativity, and perseverance. Everybody is going to have complications. We are all going to fall down. More important is to identify, be critical of ourselves, our mistakes, and then try to learn. So that is what is my emphasis on, just to give confidence boosting to majority of the younger surgeons who are watching or who will be watching my videos. I believe that good surgical judgment is the most critical aspect, and this obviously comes with experience, but our goal is to expedite that. You don't have to lose all your hair or become, gray hair to get this surgical judgment. If we senior mentors can pass on these little secrets to our younger people, the learning curve can become much more safer, smoother, and faster. That's how our training aims at. So training is the mind is what we believe in, and that is what we aspire to do, rather than focusing just on how to hold an instrument and all those things. That's important, but more important, I believe, is to stimulate them to think. That is our goal. So what our fellows we try to emphasize is they will do a preoperative evaluation for every case, even though they are not operating. Even the surgeon, the consultant is operating, but they have to prepare a notes like how are they going to plan the surgery in this patient, because once they examine the patient, they need to identify the complexities, if at all there are any, and then they have to write down all the difficulties which they're going to expect and how it is supposed to be managed. And then they present it to the consultant before the operation theater starts. So this is a way of stimulating them that how would they do the surgery if for this particular case. So from day one, we are emphasizing that importance of planning the surgery. So why fellowship with us? The only, I think, few advantages which I feel is it's going to be a very personalized training. The obvious reason is there are less trainees. So just one fellow or two fellow, and you have got an opportunity to interact day to day, and the supervisor is directly, and it's not a very, significantly high volume, like, there are 500-600 cases a month to be done. And so we got enough time to spend with the trainee. So it is not a hurried affair. So a lot of opportunity to interact and iron out the defects. And each fellow is going to be different. They having few lacunae, and a customized approach towards each trainee would be better. And this is what is our approach to training. Short-term training we currently don't have, but we are going to start in a very short time. It's going to be phacoemulsification and also maybe SICS, but phacoemulsification only for those people who already have had exposure to phaco. They already fine-tuned. They want to upscale their skills, and they're in practice, and they don't have enough time to leave their practice and come down. For those people, we are starting a short-term paid fellowship. The details will be sharing very shortly in our website. And these are our contact details, which you can contact, and will be available very soon. With this short presentation, I'd just like to conclude and thank you, Srini, for again the opportunity. And that's it. Okay. Thank you so much.
Thank you, Dr. Deepak. It's really wonderful, the points that you told. See, I was just going through my my fellowship days in Shankara. As you said, it's not in the hands. People say, okay, that and all. And one thing that you said, perseverance. See, people see. I do about 800-900 phacos in a month, and people do ask me, oh, how do you do that and all? See, and I tell them it's not exactly what you said. It's not the hand, it's the mind. Your decision making, your and it's like one of the professors said, you make complications when you're learning because of ignorance. And later on, you make complications because of arrogance.
Yeah,
so
arrogance and complacency.
Yeah,
you become complacent, arrogant and complacent.
So it's basically in the mind, and you personally training people. I think this is one center that should be preferred by all. But I understand that there is a huge rush there. But if I'm sure that your short-term phaco fellowship is going to be really successful, and I'm really happy that you agreed to join our program. It's definitely different. Like when compared to the bigger institutions, the huge volumes. I needed this part also. Because that also has to come for the completion of my program, and I'm really happy that it was you who covered that part, and thanks a lot. Dr. Dalia? Dr. Dalia?
Yes, sir. Yes, sir. Yeah. Am I audible, sir?
Yeah. Dr. Dalia is the president of Alapur Ophthalmic Society, and we are doing this program with them. Dr. Dalia, this is the last presentation for our entire program, and with the final words from you, we can conclude.
And first
Dr. Ali, voice is breaking. Dr. Dalia? Okay. So basically what we do in KSOS is that we do one CME program in association with one district ophthalmic club, so that it energizes them. The whole process being with KSOS, doing a program.
It's wonderful. I've seen you're very active. KSOS has been very active for the last 1.5. It's the most active state, state association in India. That's what I could say.
Yeah. No. We just this program itself, it just evolved over time. Like I initially thought it is going to be an SIC as this thing. Then I just keep talking to people and get the ideas from them. Right? Then I was talking to Dr. Paneerselvam Arasan. See, he's effectively a legend in this thing. And he said, Srini, see, I'm not going to concentrate on this thing. I'm going to tell about what are the responsibilities of the trainee, what are the responsibilities of the trainer, and the whole process of training. And that is when I called up everyone, all the institutions, and said, we'll do it that way. The training process. I wanted the facilities available in the beginning itself. I thought it will be video and this thing. The training process that happens in each institution, that I got from him, and I think it was a wonderful one, starting with that really wonderful. If you get time, just go through the presentation by Arvind, Dr. Adia's son, Shankar, and the boy that says each institution has a different way of. And it's nice to see, compare and take points from the Shankara Hospital. See what they do. Dr. Saptagirish didn't mention it in the end. See, the fellows who go out from there, when they start their practice and start operating on 3 cases, if it is documented and everything sent to Shankara, they give them 5,000 rupees per case, which is actually really a great incentive for them to do surgeries and increase the footfall. And also each institution has a different way to go. HV Desai Institute has a sandwich this thing. So where half the fellowship is done in their institution, the trainees on institution, half in HV Desai. So different models are there, and all are really wonderful. And Dr. Asim Sil, who does surgeries in the remotest of remote villages in Bengal. So I mean, it was great for me. This is the first program that I've sat full from the beginning to the end, and I loved presentations from everyone. I think Dr. Dalia is finding it difficult to join in, and with this,
sir, am I audible, sir?
Yeah. Yes, Dr. Dalia.
So thanks a lot for such an initiative we have taken. Actually, I didn't know that trainings are conducted in so many such centers in our country like this. So it was a good information for me also, and all the fellows and residents all our residents will have an opportunity to go about after their PG period and all. It's a very good initiative, sir. Thanks a lot for the same. And all the centers who have presented their various methods, it was actually new informations coming on. In between, to a few centers showed their surgical techniques also. So that was a learning experience for me also. So thanks a lot for all the centers who have presented, and Dr. Sreeni, we hope for you for taking up such an initiative, sir. Thank you.
Thank you, Dr. Alia. Thank you, all the presenters. Thank you, Dr. Deepak. We'll end the session now. Thanks a lot.
Thank you.
Thank you. Bye.
Thank you, sir.